Sandra Kwati.
Thank you. Good morning. Thank you all for making it to day 2 of the 2023 edition of Pediatric Conference and Child Health Research Day. On behalf of the organizing committee and on behalf of the head of Department of Child Health, I have the honor to welcome our guests and participants to the 2023 edition of the Pediatric Conference and Child Health Research Days. The Department of Child Health has over the past years lived up to the core mandate of teaching and conducting clinical research. With 14 subspecialties in the department, we continue to contribute to healthcare delivery nationally. This year's conference is dedicated to celebrating 2 decades of achievements following establishment of the Pediatric Emergency Unit at the Kofanochi Teaching Hospital. The unit remains a major contributor and a first point of call for nearly all cases coming nationally to the department. This conference is uniquely organized to bring together all healthcare practitioners from across the country. All presentations will be case-based and delivered to participants in small groups to offer them holistic participation and practical approaches to problem-based learning skills and acquisition. And we did that yesterday. Today, the second day of the conference, would focus on scientific dissemination of our research works as a department. We would have a plenary session delivered by our keynote speaker, the Pro-Vice Chancellor, who continues to offer immense support to the department. Prof, we are very grateful. And I must say he's also a major sponsor of this program. The oral presentations will cover all subspecialties. We are also excited to introduce the nursing presentations and presentations from our colleagues, the district and regional hospitals. So pediatricians from district and regional hospitals also have the opportunity to present their research work today. Our team of judges who have been selected will help us select our best abstracts, oral and poster, at the end of today's sessions. I wish to thank the head of department for offering me the opportunity to lead the planning committee and the organization of this very important event. I want to thank all invited guests who agreed to support this program in diverse ways. I also want to thank the management of the Kofanochi Teaching Hospital and our sponsors, UNICEF, the Thai Vega Study Group, MDS Lancet, and all of you who are here. We are highly indebted to you. Finally, with a deep sense of gratitude and pride, I say thank you to the members of the organizing committee for their sacrifice, commitment, and dedication throughout the planning process for this 2023 edition of the Child Health Conference and Research Days. Team members, I am extremely grateful for all your support. Thank you very much.
Thank you, LOC Chair, Dr. Sandra Kwati Owusu. All right, so a little bit of profile of our conference chair. So Professor Philip Ntrieje is the Director of the Office of Grants and Research. And Professor Ntrieje has won several international grants, published extensively in leading international peer-reviewed journals on climate change issues. He's a visiting researcher at the Sustainability Research Institute and the Center for Climate Change, Economics and Policy at the University of Leeds, United Kingdom. His vision for the OGR, in line with that of KNUST and the Vice Chancellors, is to improve grantmanship, increase scholarly output, enhance research dissemination. That's why you see him here today. This is like one of his babies. He really wants people to be involved in research and research dissemination and visibility, and then enhance research culture in KNUST. Professor Ntrieje seeks to drive the Vice Chancellor's vision of making KNUST a research-intensive university. That's why he's also here, because most of us, as you see, we are lecturers in the KNUST and also work in Confanoche. So it's just holds dear that he is the chairperson for our research day today. Professor Philip Enchiji.
The Pro-Vice Chancellor of our great university, the Kwame Nkrumah University of Science and Technology, Professor Alex Owusu Debo, the Provost of the college, who I'm told will be represented by Professor Samuel Newton, Dean of the School of Medical Sciences, Professor Akwasi Entry Kusi, Head of Department, Child Healthcare University, Professor Samson. I'm told Samson with P. So as soon as I heard that, I checked my notes, and luckily enough, I had P in mine, so I think I'm okay. Members of the media, distinguished ladies and gentlemen, good morning. Good morning. Oh, I said good morning. Good morning. At least respond so that we can go. It is indeed an honor for me this morning to be invited as the chairman for this year's Conference and Child Health Research Day. Pro-Vice Chancellor, kindly permit me to express my profound gratitude and utmost appreciation to the Head of Department of Child Healthcare University and Organizing Committee for this year's Pediatric Conference and Child Health Research Day for this invitation. I would like to also commend the Organizing Committee for choosing such an important theme for this conference, ensuring excellence in emergency care for all children 20 years on. Indeed, there couldn't have been a better choice of theme for this year's conference and research day than this one. This theme, I'm told, has been carefully chosen to reflect the Department of Child Health's unwavering commitment to improving healthcare and survival for Ghanaian children. The theme also reflects your commitment towards the attainment of the United Nations Sustainable Development Goal 3 that seeks to ensure healthy lives and promote well-being for all at all ages. Research dissemination is a key component in the conduct of research, and this is particularly critical for the medical community, where information from research is a crucial catalyst for improving patient care. Research dissemination makes available our research fundings to end users to improve the socioeconomic development of our people, whilst influencing national and regional policy making. Distinguished ladies and gentlemen, the Kwame Nkrumah University of Science and Technology, through its Office of Grants and Research, remains committed to providing research support services to all staff in their pursuit to conduct research, as this is one of the university's core mandate. In this regard, KNUST, as the #1 university in quality education for SDG 4 globally, that one, if you don't applaud, I'm not going to continue. Seeks to advance knowledge in science and technology through the creation of an enabling environment for undertaking relevant and impactful research that improves the quality of life. The Office of Grants and Research under the Vice Chancellor's Office supports the growth of the research enterprise of the university through the identification of funding sources and assistance and guidance in preparation and submission of proposals. The office champions the research intensiveness agenda of the university, and our doors remain open, so you can always call on us when the need arises. I have looked at the various abstracts being presented, both oral and poster, and I must admit that these abstracts cover a wide range of relevant and contemporary topics in pediatric emergency care. These presentations will provide unique opportunities for learning and future research ideas aimed at improving care. This will also provide networking opportunities for future collaborative research endeavors. Vice Chancellor, let me at this juncture congratulate the Department of Child Health, both at KNUST and the Confanochi Teaching Hospital. And I believe that these events will continue to become bigger and much more better. With these few words, I wholeheartedly accept to chair this important conference and respectfully treat all participants to fully engage in all discussions that will take place today. I wish you fruitful deliberations, and I say thank you, and God richly bless us all.
Thank you, Prof. All protocols observed. I would like to call the head of directorate and head of department of child health and pediatrics in KSMD and then Confanochi Teaching Hospital, Professor Samson Entry, to give his address, please.
So good morning. So the Pro-VC, who is here in his own capacity and also representing the Vice Chancellor. Then the Chair and Director of our Office of Grant and Research, Professor Philip Ejay. The Dean of KSMD, Professor Njukusi, former Dean, Professor Anson, former Vice Deans, current Vice Dean is also here, Professor Safo. He is also here as a judge on the scientific presentation. So the team of judges, I see Washe also there. And our charity sponsors, we are so happy. You have two of you represented here, UNICEF. We are so grateful of you. Because I think funding is a major consideration in organizing a conference like this. And in our maiden conference, you supported us greatly, and you have done it again. We are very grateful to you, UNICEF. Colleagues from far and near, we are really happy to see a lot of people from the districts across the country, not only in the region, here, from Volta, from Western, and Bono, and the rest. Eastern, yes, I should also leave you. Greater Accra is also here. Many more regions are here. We are so happy. And I must say that we are grateful to the Almighty God for His sustenance. 2 years after the maiden research day that was celebrated in 2021. When we say we are grateful, I hope you understand it. 2 years is long enough. A lot of things might have happened. But God has sustained us, and we are so grateful. As most of you are aware, the Child Health Research Day was a fresh innovation that was instituted by the academic and the clinical department of Child Health, both KNUST and Confanochi Teaching Hospital. It was instituted as a biennial conference, basically to stimulate the various subspecialist units and individuals in the directorate to translate their huge clinical experience and data into scientific work that will ultimately translate into evidence-based medical practice. So it was also, and still is, intended to see many publications churn out from our directorate. Already the Child Health Directorate is noted for its strong research output to various collaborators within and outside the shores of Ghana. My office is yet to be updated with how many of the research work that were presented 2 years ago have been published in scientific journals. But I'm aware that all the abstracts that were presented 2 years ago were published by the African Journal of Current Medical Research. We are indeed grateful to the director and his team for that gesture. It is my hope that presenters at this year's Research Day will develop their conference presentations into full-fledged journal manuscripts for publication. And I must announce here that I'm definitely going to consider appointing a research coordinator for the directorate to oversee this drive. Yesterday, the annual Pediatric Conference of the Directorate that has run for the past 20 years resumed successfully after it was temporarily suspended in 2020 because of the then raging COVID-19 pandemic. And it went so well. I was so happy about the spectrum of cases that were discussed. They are all emergency cases and they are subspecialty based. And I'm sure audience, we had a very good, rich expose to various ways of managing emergencies. Now with the pandemic over our heads now, we hope to keep this pediatric conference every year. And so take note of that. Every year we're going to do that. And it is going to be combined with the research day as a twin conference in alternate years, as it has been done for this year. So the research day is meant to be a biennial conference, but we're going to maintain our pediatric conference every year. And so in alternate years, it will be a twin conference, both pediatric conference and research day, as you are witnessing now. I employ every participant to make the most of the opportunities that this conference offers. I said that yesterday. The research works by UNIS should open the eyes of our senior residents in our midst to the various research opportunities that abound in the directorate and prepare them towards their fellowship dissertations. So as people are presenting their research work, definitely let it open your eyes for you to know that you could also fashion your dissertation research along those lines. I see this opportunity to express the directorate's deepest appreciation to LOC. And they worked so tirelessly to put this together. The decision even to hold it this year came quite late. Yet they've done a human job for putting this beautiful conference together. So I equal to Sandra and your team. And once again, I will say that enjoy the ambience that the conference venue offers. I'm sure you can all testify to the tasty meal that Godi Bean offers. So with this, I welcome all of you to the second edition of Child Health Pediatric Conference 2023. Thank you.
Thank you, HOD, Professor Samson Entry. Now, we are going on to our keynote address, which will be given by Professor Ellis Owusu-Dabo, but I'll give a short summary profile of who he is, and this time not as a big brother, but in the person of the Pro-Vice Chancellor, and as he's standing in also for the Vice Chancellor. So Professor Ellis Owusu-Dabo is a public health physician specialist in medical epidemiology, and also, as I've been saying, and everybody has been saying, he's the current Pro-Vice Chancellor of the Kwame Nkrumah University of Science and Technology. He's a professor of epidemiology He's a professor of epidemiology and global health. He's the past dean of the School of Public Health and the immediate past scientific director for the Kumasi Center for Collaborative Research, which we cut it short all the time, calling it KCCR. His office is one of our sponsors for this year's conference, KNUST International Vaccine Institute. They are one of the people that gave us premium sponsorship for this year's conference. Can we give them a clap here? And then I would like to say that he has successfully mentored students, of which I'm part. I don't even know why I'm calling my teacher my big brother. He taught me in medical school. Charlie. He taught us in medical school, and we are successfully here. We are lecturers now. He's still teaching us, impacting to us. And then junior faculty, he's helping junior faculty into developing a wide network of contacts throughout Ghana, as well with foreign education and research institutions. He has considerable interest in population genomics of pulmonary tuberculosis, and he's a fellow of the West African College of Physicians and Surgeons and a member of the American Society for Tropical Medicine and Hygiene. He's currently the chairperson for the Executive Steering Committee for MasterCard Foundation, Africa Higher Education Health Collaborative, and the program lead for KNUST MasterCard Health Collaborative. He's the director, as I've already said, for KNUST IVI Collaborative Center, and he's leading the EOD research group to undertake clinical trials and surveillance in infectious disease, such as typhoid. My audience, may we all give a round of applause as we welcome Professor Ellis Dabo to give his keynote address, please. Yeah, and he here us on his behalf, and then on the behalf of also, as I said, the Vice Chancellor. Thank you very much.
I thank you so very much, for those kind words of introduction. I'm so much excited about the Department of Child Health and the fact that you are leading and living up to your core mandate of research. This is who we are, particularly those of us in the university. This is who we are, and I know that it is not one or the other, but it's a cycle that you have to pursue until you become a junkie, of research, seeking knowledge, and disseminating knowledge. So you seek the knowledge, you propagate the knowledge, you have additional research questions, you seek the knowledge, you propagate the knowledge, you have more research questions, and then you become a junkie. So it never dies out. But the important thing is that we profess solutions for the improvement of our communities within which we research. The Chairman and Director of the Office of Grants and Research, Professor Philip J. The representative of the Provost of the College of Health Sciences, the current Dean, School of Medicine and Dentistry, directors, former Dean and Vice Dean of our great medical school, heads of department and directorates, and I just want us to give a standing ovation to our current head of department and of the directorate, Professor Samson Entry, Kwame Entry. Yeah, and I want to emphasize the P. Yeah, I want to emphasize the P. I have tried to dovetail the Vice Chancellor's remarks. So in my opening remarks, I will just say a few words from the Vice Chancellor, and I'll continue the keynote. Chairperson and members of the organizing committee, esteemed invited guests who are here this morning, our cherished media team who are working so hard to put out the message out there so that people will get to hear and know what we are doing. Ladies and gentlemen, it gives me great joy that I have been invited to deliver the keynote, but as I've indicated, I'm going to say a few words and read it verbatim, from the Vice Chancellor's presentation, and then I'll proceed to give my keynote. The Vice Chancellor indicates that your theme for this year's conference, Ensuring Excellence in Emergency Pediatric Care 20 years on, expresses the contribution and commitment you have made to child survival and improvement in this nation and certainly beyond. Your contribution to the Sustainable Development Goal 3 cannot be overemphasized. The whole university community celebrates the department on its great achievements over the last 2 decades. The core mandate of the Kwame Nkrumah University of Science and Technology is research, teaching, and provision of community service. This year, the Kwame Nkrumah University of Science and Technology has been ranked as first in helping to achieve the United Nations Agenda 2030 SDG 4. Thank you so very much. Yeah, I will reemphasize that because it's no mean an achievement, and it's coming from the Times Higher Education. Whether you believe it or not, that is what it is. And we speak to data, don't we? So this year, the Kwame Nkrumah University of Science and Technology has been ranked first in helping to achieve the Sustainable Development Goal 4, and we have been ranked as the #1 destination for quality education globally. I say this because research is a key component which enables KNUST to achieve this feat. It's the reason why it's coming because of what you continue to do. Therefore, your research dissemination as a department contributes significantly to the attainment of this feat. Standing on this achievement requires that together we continue to work hard in the areas of research, teaching, and the provision of community service and impact to enable us to maintain this position, which is very enviable. Events of this kind will contribute in no mean way, but very immensely for sure, towards the collective achievement of this pivotal goal. I am also delighted to see senior faculty members of the School of Medicine and Dentistry mentoring senior and junior residents, medical officers, nurses, and pharmacists as the next generation towards ensuring that research is our core mandate. And on this note, she congratulates all of you and wishes us all very well. Now, I shall proceed with the presentation. Let me organize myself here for a second. That should be fine. Right. You always need a few minutes for technology, it's fine. The timing of this conference is really great. It's very important that we look at this in the context of what we're doing as faculty and, of course, as service providers. It couldn't have been at a better time. And I want to say to the indefatigable, where's Dr. and Mrs. Sandra Ozukwati, the chair, and all the members. Let's see the local organizing committee members. The chair, and local organizing. Excellent. A round of applause for these ones. Excellent. It's not easy to put together a conference. It's not easy at all. Thank you so very much. Thank you. Thank you. Thank you so very much. You may resume your seat now. Now, let me say that if you're a CATH staff, it is indeed a privilege to work in the second largest hospital in this country. One of the best in West Africa for sure, saving lives of Ghanaians and many others who come from neighboring countries. And if you're a KNUST staff, or if you're one that is aspiring to be one of us, I hope that this is my thing. I think you should take this one away. Very small podium, so I have to organize myself. Right. Similarly, if you're aspiring to be one of us, count yourself a privilege to belong to the best university, as I've indicated earlier. And I want to dwell now on our topic, ensuring excellence in emergency pediatric care, 20 years on, and look at what we can potentially hear together. Socrates once said, "The unexamined life is not worth living." And therefore, for us, once you have selected this theme and topic, it means that you want us to examine our lives. So you have really, for the organizers, you have hit the nail right on the head with your chosen theme, ensuring excellence in emergency care, 20 years on. Out of 1,000 live births in Ghana, 48 children have the probability of dying before achieving the age of 5. This is still a very worrying situation. The actual practice of emergency care is as old as medicine itself. The oldest medical script existing is probably that by Edwin Smith, which indicates the papyrus circa 700 BC. Emergency care was already well described at that time. An example was one of the cases which read, "If thou examines a man having dislocation of his mandible and mouth is open, thou shouldest put thy thumb upon the ends of the rami of his mandible and your 2 claws under his chin, and thus reduce his dislocation." 700 BC. This method for reducing jaw dislocation is still the standard procedure today. The examples of emergency care can be chronicled throughout history. The biblical story of the Good Samaritan is a typical example of emergency care. Emergency care found its usefulness in many battles and wars throughout the history of humankind. Florence Nightingale, for instance, made name for herself during the Crimean War in 1854 when she offered emergency care to wounded soldiers, reducing their chances of dying from 1 in 3 to 1 in 40. Just wound care. However, formal emergency medicine gained its recognition, as we're all aware, as the 23rd specialty in 1979, when the emergency training began simultaneously in the United States and UK, and it spread all the way towards Australia and Asia. Then other parts of Europe to Africa later. Although we caught up, as always, we catch up pretty late. But now we're far advanced, and particularly for Ghana, I'm very, very proud for what we've done in the last couple of, almost 2 decades. In Africa, the first emergency medicine residency training began in 2004 in South Africa's University of Cape Town, Stellenbosch University. In Ghana, though, there had been a lot of research and pilot training programs recommending the need to establish a formal emergency care system, including what held with emergency, the one that we held with the University of Michigan. It appears that May 9, 2001 stadium disaster, which led to the death of 126 individuals and many more sustaining various forms of injury, probably garnered the momentum for the political minds and policymakers to take the long-awaited necessary action towards the establishment of emergency medicine as a discipline. The building and completion of the supposed 100-bed capacity A&E unit at the Konfanochi Teaching Hospital in 2008 gave birth to the formal training of emergency medicine in Ghana in October 2009. Ghana thus became the first West African country to begin emergency medicine training as a specialty, joining a handful of African countries at the time, South Africa, Botswana, Tanzania, and Sudan, that locally trained emergency physicians. How many of us here are real-time witnesses of how events were at the Konfanochi Teaching Hospital? In fact, it was the reason why I tried to get this is the A&E. I tried to get some historical pictures of the Konfanochi Teaching Hospital, and I'm sure that many of us, who have spent over 40 years, they are senior gray hairs amongst us. So, you recall the trajectory of the Konfanochi Teaching Hospital and where we have come from, in terms of our development. Though currently, as it is in most developing countries, there is no formal pediatric emergency training in Ghana, I believe no matter the extent of our lenses opaqueness, we can attest to the successes that we have chalked over the last 20 years. So 20 years on, what have we achieved? We remember vividly as if 20 years ago was just yesterday. We remember when some rudimentary areas were dedicated as casualty centers. The name itself was inimical to our belief and practices, casualty. As casualty centers manned by medical officers, relatively junior ones, with little support from seniors. You could imagine the potential and risk for complications and deaths, disability and deaths. The designation of casualty center made the place unfriendly to both medical and non-traumatic surgical emergencies. The emergency cases were seen at the polyclinic, and later quarter or half or sometimes zero stabilized patients were sent to the ward, where the pediatric wards rotated on several days. They would receive patients from the polyclinic. We remember the confusion that sometimes would ensue and the petty squabbles when a particular ward's duty roster saw large numbers of cases, the ward's capacity was outstripped, and the off-duty wards had to step in order to contain the spillage. Prior to the establishment of the pediatric emergency unit, you could imagine a partially stabilized or sometimes non-stabilized child with seizures or kwashiorkor in shock who would have to make way for reasons of extremely limited space at the polyclinic for other fresh emergency cases. These non-stabilized patients will then have to be wheeled upstairs and sometimes via the staircase because of broken down elevators. And sometimes we didn't even have the wheelchairs. Also, UNIT has offered practical and hands-on pediatric emergency care training to pediatric medicine residents, medical officers, house officers, medical students, PharmD students, and trainees of the Ghana College, and certainly those in the nursing and midwifery field. We have indeed come very, very far, and I think you deserve a round of applause. Emergency medicine is a medical specialty based on the knowledge and skills required for the prevention, diagnosis, management of the acute and urgent aspects of illness and injury affecting patients of all age groups with a full spectrum of undifferentiated physical and behavioral disorders. The International Federation of Emergency Medicine has documented the standards of care for children in emergency departments against which excellence must be benchmarked. And I will try and highlight on a few of those situations or the standard operating procedures that are required. I just want to show a few of the pictures of where we've come from, and good or bad, this is our history. And in fact, in some instances, they still remain the same. I'm aware where we've come from. And the other day, I don't know how old that old structure that we're trying to refurbish, is it 30 or 40 years old? 40 years old. Yeah, and it still sits there. We've come very far. Let me just run us through some of the benchmarking as far as excellence in emergency pediatric care are concerned. Number one is an integrated service. An integrated service. An integrated service. Pre-hospital primary care and hospital services for emergency pediatric care must be integrated, and the roles and capacities of each emergency department within the regional network should be made very, very clear. This should lead to a communicated strategy and framework shared with stakeholders within this network and coordinated such that emergency medical services can gain access to all specialists with pediatric specialty that will be able to seek advice to emergency department and must exist 24 hours a day by telephone, telemedicine, internet, or in person. Child and family-centered service. Child and family-centered care must be a priority for staff and managers through clinical practice, through staffing and environmental design. The emergency department's environment must be safe, it must be friendly for all children. The pediatric areas should look attractive to children and aid in distraction from the stressful environment, and therefore examples will be the provision of toys, reading books, play tools, and so on and so forth. Also, children must be separated from distressing sights and sounds of patients, with some separation from the main waiting area for adults. Now, we just have to examine ourselves whether we are benchmarking ourselves as far as excellence is concerned in the area of child and family-centered services. The option of a family member presence must be encouraged for all aspects of emergency care. Quick initial assessment of all ill or injured children and their stabilization. Every child arriving at an emergency department must have a rapid visual inspection very soon after arrival. All staff members, including non-healthcare qualified, must be trained and empowered to alert others to the arrival of a seriously ill child. Communication gadgets are therefore necessary, particularly during the referral process. There must be no barriers to accessing immediate initial assessment by a qualified staff member trained in the recognition of serious illness in children. 4, adequate staffing of the emergency and definitely adequate training is required. Investigations and treatments are more difficult to perform in children, as we all know, and may require a different approach. Therefore, emergency department staff must not work long, continuous shifts. Example, 12 hours. As fatigue leads to patient care errors. These are the standards for excellence. As fatigue leads to patient care errors, I have to say that in your case, apart from working 24 hours, you also use your pocket money to look after them. As fatigue leads to patient care errors and decision making. Somebody was telling me the other day how of all the principal decisions that are made, they are made by, these top, when you hear that G20 or G8 or G7, whichever, is meeting, all these big people, when they meet, they are being briefed on the planes, you know that. They are tired, they are flying over the Atlantic and all of those places, and sometimes they arrive so tired, and somebody was questioning the decisions that they make, whether they actually had rest in order to be able to make those decisions. But look at you. I mean, all of us work around the clock, particularly for those of you in pediatric emergency. That is really a sacrifice that you're making. But when you are tired, it has a toll on you, on your decision making and your judgment. There should be appropriate organization of pediatric specific equipment, supplies, and medications that allows for staff to access them quickly and safely during resuscitations. In academic institutions like ours, Konfanoji Teaching Hospital, clinical staff members must have sufficient protected non-clinical time for other aspects of their job. When I paid a courtesy call and I told the Konfanoji Teaching Hospital 2 weeks ago, I was sad, Professor Samson Entry. I was very sad, because doctors, we don't look after ourselves. We don't look after ourselves. And I think it's about time that we said this to ourselves. Sometimes you can look at yourself in the mirror, and although you are a cat, you're looking at yourself and thinking you are a mouse. I think as one of your own, we need to take what is ours. We look after everybody else but ourselves. And therefore, you will work and not complain. You will work, and even if the place is dirty and has not been cleaned, the doctor will still keep quiet and look after his or her patients. And I think it's about time that we looked into that. Your own safety. Because you must survive to save the if you don't know how. I mean, in our case, all these filthy environments and so on, they impact on our lives, our quality of delivery and the sort of things we do. And I must say this to us. I'm saying to myself too. Let's look after ourselves well and demand our pound of flesh. What are we looking for? Just clean environment, clean offices, clean bedside, clean spaces for research, data gathering, and so on and so on. They're basic things. A typical doctor doesn't look for much. Typical doctor. Because that's how we're trained. But the point is that you can't sit in an environment that is so discomforting and yet you won't say anything. Please. Okay, I'm expecting that if things are not working well as far as your welfare is concerned, you rise up, speak about it, and you have to protest it. Say it. So that the situation can be changed for our own good. It's important. I'm passionate about this. That's why I paused to say this. Because we just keep working and working and working and working because, everybody is looking up to you. But your welfare is critical. I needed to say this to you. Yeah, I needed to say this to you because I think that we deserve more. And we're not asking for anything. Just working air conditioners, just good chairs, just a place to pee when you're on duty. A place to pee when you're on 24/7 call or 24/3, 24/2, whichever it is. A place to pee, doctor. And you've kept quiet, you are peeing in your hand wash basin, you've kept quiet. So we need to talk about it. One of the many challenges, I'll move on to the fifth point, adequate equipment, supplies, and medications. Adequate equipment, supplies, and medications. One of the many challenges for treating patients of all ages in an ED is ensuring availability of equipment and medication in sizes, formulations, and quantities that work for various ages and body weights. The ED must be well equipped and organized with easy access to the necessary equipment, the supplies, medications needed for the care of the acutely ill or injured children of all ages on a 24-hour basis. And I'm expecting that access to these, importantly, is accountability. But when you need it, as a physician on duty at the emergency department, when you need it, you must be able to access it. So there's no question or room for, the key is with the stores and somebody's dying. Okay, we must be able to have access to the those equipment and supplies. In developing countries like Ghana, where the recommended pediatric emergency equipment or medications are not available, informed and rational decisions need to be made regarding suitable alternatives. I'll move on to the sixth point: quality of care and safety of our children, patients. Patient safety is a concern in all emergency departments. Due to the nature of the environment, such as competing demands for staff, high patient acuity, rapidly changing situations, overcrowding, multiple interruptions, lack of patient familiarity, literacy or language barriers, clinician fatigue, and numerous factors, it is important to take quality of care and safety critical. Processes for safe medication storage, prescribing, and administration should be established and should include the use of and pre-calculated dosing guidelines for children of all ages. The next point will be well laid down policies, procedures, standard operating procedures, and guidelines. To manage risk in this high volume, highly diverse, and highly changing environment, it is very useful to have policies, procedures, and guidelines written out and pasted in places that people can see. It must include the issues about the general assessment and management of pediatric patients in an emergency pediatric unit. As the emergency care system matures, emergency care managers should be incorporated into the planning and management of the system with evidence-based clinical care practical guidelines for improving child survival. Well-established information system and periodic data analysis, which is what you're doing here. And I'm so delighted that a lot of the data, the information that you've gathered from research that you have conducted is informing your practice at the teaching hospital. Well-established information system and periodic data analysis. For an emergency department to function excellently, it needs to know the key information such as how many patients are in the emergency unit, how many of them come with febrile illness, and which of the sepsis or febrile cases belong to which, and which belong to a high priority. In other words, a proper triaging system be put in place. Emergency departments should exploit information technology to achieve full computerization for cost-effective patient care, reduce medical errors, and promote patient safety. Adequate provision of pre-hospital care. Pre-hospital services in emergency situations, which in Ghana are the National Ambulance Services, facility-owned ambulances, and few private ambulance services, must define the level of pediatric skills that are required. These will impact on the outcomes of the various emergency situations. All pre-hospital care should be trained to safely assess, manage, and transport common pediatric emergencies to a predefined level within the pre-hospital emergency network. This includes scene awareness and familiar reassurances and how to be able to transport these patients. I will move on to adequate provision for mass casualty or patient surges. Staff training programs for pre-hospital and hospital personnel should include coping with surges and major incidents in pediatric emergency units. Pre-planned and designated sites within the hospital for decontamination and management of patients in these units must be in place and consider child casualties. And I've come to the 11th, and that should do for our excellent benchmarking. Provision for adolescent mental health and substance abuse and misuse, or for the abused child. Despite the difficulty in detecting cases of potential child mistreatment and maltreatment, emergency staff must be able to recognize and manage children presenting because of abuse or neglect. Clear protocols supported by simple flowcharts and checklists should be available in the emergency unit. This will improve awareness, identification, and documentation of cases, protocols, clinical pathways, and assessment tools to improve the health outcomes of these children. I shall end very soon, but before I do so, let me just walk you through what is known as the Pacific culture and relationships as a model before I talk about the way forward, and then I will conclude. Now, as you can see here, we have a cycle, a very interesting one. We have teamwork and collaboration. You have respectful communication, capacity building, advocacy and diplomacy, regional partnerships, surge event experience, emergency care recognition, commitment, and teamwork. Now, when you look at the yellow arrow, it's all about the need for us to be able to collaborate. Remembering that a lot of these emergency situations that we find, I mean, C-19 taught us a lot of things, didn't it? I mean, if you're thinking that you're sleeping in your small corner and that it doesn't concern you, you're making a very big mistake. So the first thing is that we are in this together as a team. And I want to applaud the Department of Child Health for sticking together as a team. I think this needs mentioning. Well done, Child Health. Respectful communication, capacity building, which is what you're doing today. Advocacy and diplomacy is very, very important. Who are our regional partners as far as emergency and child health?
Acknowledge Dr. Emmanuel, is it Tevu? And he's from Ghana Health Service, Regional Health Directorate. And he's standing in for our regional director, who for one reason or the other couldn't come, but definitely wanted somebody to represent him. Dr. Emmanuel, thank you for coming. Thank you very much. All right. Now we're going to hear something brief from our title sponsor, which is UNICEF. And it's going to be done by Dr. Chermatin Amoa, one of our own, who is now a health specialist with UNICEF. After Dr. Chermatin Amoa finishes, we are going to hear something a bit on UNICEF's mandate theme by our former dean, Professor Anson. He's just going to continue to give a small presentation just after Dr. Chermatin Amoa. Thank you very much.
Thank you very much. Good morning, ladies and gentlemen. I'm happy to be home, and I feel humbled and delighted to be with my mentors and my teachers. Most of the distinguished professors here taught me and mentored me, and I've seen colleagues. And thank you very much, our teachers and our professors, for your passionate and continuous work in providing such great human resource, shaping this country in all spheres. Professor Chairman, permit me to stand on all the existing protocols that has been already established by previous guests. And taking inspiration from Professor Ellis Dabo, let me please ask that we all rise. I think we've been sitting for a while, so that we look after our own selves, just stretch a little, and let the, different muscles take over and the circulation and all that, and then we can resume our seat. Thank you very much. You may please resume your seat. So I bring you greetings from the Deputy Country Representative at UNICEF and from the Health and Nutrition team. And we at UNICEF are very pleased to partner with the Child Health Directorate of CATH and the KNUST on this Research Dissemination Day. Now more than ever, targeted research is needed to understand the challenges that confront us as healthcare providers, to stop practices that have outlived their usefulness, and to replicate interventions which have proven to be successful. At UNICEF, our vision for 2016-2030 is a world where no child dies from a preventable cause and all children reach their full potential in health and well-being. UNICEF and the government of Ghana have developed a joint country document for the next 5 years, that is from 2023 to 2027. And this program document has 4 main output areas. 1, increasing access to quality health and nutrition services. 2, strengthening health sector governance and financing. 3, strengthening emergency preparedness and response. And 4, increased data quality and evidence generation for advocacy, policy, and decision making. Therefore, we are particularly pleased to partner with this Research Dissemination Day because it aligns with our output 1, which is increasing access to quality health and nutrition services, and output 4, which is increasing data quality and evidence generation for advocacy, policy, and decision making. We are of the view that when health workers generate and utilize high quality data at the point of care, the quality of health will improve for all children and adolescents. Professor Chairman, let me congratulate the efforts of the institutions for putting this conference together. And I think at this point, they deserve a big round of applause again for all the effort and all the hard work. Thank you very much. We encourage the organizers to share the findings from this conference widely to relevant stakeholders, including policy makers. This conference should be a good platform to build data management and research capacities of health workers in both urban and under-resourced areas so that no child is left behind from the benefits of cutting-edge research. And let me pause here and say I was very happy yesterday as I joined some of the skill sessions where we were taking through various sections, and the audience are coming from all over the country. Thank you very much. I think you deserve a round of applause where we are strengthening the peripheries and impacting them with the knowledge so that they can take care of cases even before they come here. We encourage the institutions to continue their efforts in UNICEF's focus areas, which includes newborn care, non-communicable diseases, environmental health, nutrition, and adolescent health, among others. And now, more importantly, we also want to urge organizers to particularly look into translational research, which seeks to produce more meaningful and applicable results. And evidence of successful interventions and innovations should be shared. And together, we will be happy to explore ways of replication to benefit more children and adolescents. Yesterday, I was having conversation with Dr. Davy, and we're talking about some of the poisonings and things that children come into the hospital with, and one of them is all this caustic soda ingestion by women who make soap and causing strictures and so many other things that are happening. And we'll be very happy to see what we've done that works and what we can replicate and expand so that we can build our primary health care, which will eventually trigger up into the tertiary institutions. Ladies and gentlemen, before I conclude, let me give a brief word on some of our emerging environmental health risks. As a country, children are confronted with exposures to many chemicals, such as mercury. And I think, is it this year, we had the ASGM for the Pediatric Society. We mentioned mercury, and it's not stopping. We know the Galamsey issue. We are dumping tons of mercury into our river bodies, and only time will tell the implications and the outcome and what we are doing to ourselves. And we want to encourage healthcare providers to have a high index of suspicion as cases come to you. Begin to ask and be interested in the environment that your patients are coming from, and perhaps we can all rally and make our voices stronger and louder for all of us as a country to curb this menace. Other chemicals such as lead and corrosives and others, air pollution from industrial, outdoor, and at home, and the impact of the changing climate. And I think if anyone in this room ever doubted the issues of climate change, the spill that we've just witnessed due to excess rainfall will turn your mind around to let you appreciate the fact that we are indeed having climate that is changing, and it has impact on the vulnerable, being our children and women. 2022, UNICEF, Ghana Health Service, and Pure Earth conducted the first major study in the country on blood lead levels among children 12 months to 59 months in Ghana. And the regions were Northern region, we came to Ashanti, and then also Greater Accra region. And we sampled about 3,222, 3,227 children. And this is just a snapshot of the work that has been done. And among these children, more than half, 53.5% of them have blood lead levels greater than 5 microgram per deciliter. And this is the level at which WHO indicates that there should be action taken. Children should be removed from the exposures, and we should monitor and go through all the necessary precautions for them. We all know that lead has serious implications on the central nervous system and other learning capabilities, kidney, and so many other things for children and also for adults. And this is yet to be published by UNICEF, Ghana Health Service, and Pure Earth. And there are so many other work that has to be done in relating the diseases that we experience in our various facilities, the emergency cases that we get. Yesterday, as I sat and listened to Professor Entry, looking through some of the acute issues that affect the lungs, kidneys, I beg your pardon, airway management and asthma, you see that a lot of these do have influences from the exposures in the environment. UNICEF Ghana is committed to partner with the government and with institutions like the Child Health, Konfanoche Teaching Hospital, and the School of Medicine and Dentistry to drive the agenda of health and well-being for the people of Ghana. We wish you fruitful deliberations at this conference, and wish you well in all the endeavors. Thank you very much.
Thank you, Dr. Chirmati.
Good morning, Mr. Chair, the Director of Office of Grant and Research, the Pro-Vice Chancellor, our keynote speaker, and coincidentally representing the Vice Chancellor, the Head of Department of Child Health, the current Dean of the School of Medicine and Dentistry, or other protocols observed. I quote, "Medical care without research is like a moving car without a driver," unquote, by Professor Ellis Owusu Dabo. And that should resonate with all our activities that we do. I'm here to present for the Department of Child Health on behalf of UNICEF, who have sponsored us immensely towards this. And we are most grateful to UNICEF and their support. Right, my presentation will look at a very short introduction because most of the things that the Pro-Vice Chancellor touched on were my introduction. In case of data use, PEU was used as a case study, what he has done for the last 2 decades. How to organize the data, and also what is it that we can show in the past, what are our strengths, weaknesses, opportunities, and threats as a department generating data to improve care, our next steps, and then I will conclude. Interest in evidence-based clinical care should be underpinned by data. That is why that car without the driver is very important. Health institutions should invest and pay attention to accurate data, because if you use data that is not correctly collected, you would make wrong informed decisions and create problems for your patient care. Accurate and credible data generation requires planning, time, human resources, as well as medical research or material resources that will come with the medical research that you would done. And so we would need all this to be able to be successful. Now, in our pediatric emergency unit, which was established in 2004, the first emergency unit in Kumasi that runs 24 hours since 2004. So since 2004, the department had not gone to sleep. Trained staff and for clinical care. Its core mandate, clinical care, research, and teaching. Based on the fact that we are here Research Day, I'm aware that case reports, case series, cross-sectional studies, clinical trials all currently take place in the pediatric emergency unit. Teaching, it's one of the byproducts that always goes on in there. Now, we would want to now look at what are the sources of data that comes to the PEU. Histories from caregivers, histories from health professionals, the clinical information that we generate, both physical and measurements that we generate, the laboratory, the chemistry, the hematology, and mention are key sources of information. In addition, other sources of information also come in there. The radiological information with contrast or without contrast, other imaging studies. So if you sit down and you look back, you would see that we have core areas where we generate research data. Data that we can use to inform decision and to make change. Very important. Now, what data is relevant for the emergency care? Because not all data that you can rely on. And one, the data should be systematically collected. Data collected in a fashion that is verifiable. It's very, very important. Data sources are always available. Your sources of data, you should be able to find it, and you should be able to verify the data source. And it should be a continuous collection of the data to be able to use it. You should have a standardized way of collecting it. Otherwise, you would have heterogeneity of your data, and you may not be able to use it well. And so you train your staff so that they would all be doing the same thing. Now, the data should be protocol driven. You cannot just wake one day morning and say, oh, I think there are so many cases of children who are having amnesia. So I want to test amnesia in children. You see, that research question may not be appropriate, depending on the age. So it should be protocol driven, and it should be team-based. Compliance to standard operating procedures that is there, so that your data that you collect, you'll be able to use. Again, you should apply to all the ethical standards, because pediatric populations are vulnerable populations, and you would always need to protect them. And so paying attention to the ethical issues surrounding all pediatric research work is very important. Now, accurate data, credible data. The collection should be timely, and it should be reliable. These would come on and on and on all the time. The types of data that currently comes out from the PEU is interesting. We have cross-sectional studies that are going on. A typical example is the typhoid study, the pneumonia study. You have data from our cohorts. You would bear with me that we have over 25 years of cohorts of sickle cell disease patients. The asthma cohort data is also coming into the PEU. And so data that is being collected on a continuous fashion is also available in there. Data from surveillance, our collaboration with the World Health Organization, and we would want UNICEF to also come in to support this program. Collect data on meningitis, data on diarrhea diseases, and we have about 10 to 15 years of poisons data, all the poisons that come to them. Again, the most important thing is that once you collect the data, you must respond. You just don't collect the data and respond. In some of them, there are good response. Some of them, we are still not progressing. There are clinical trials that are going on in the department. The Severe Malaria in African Children Network data and its research outputs, very important to inform the current practice in malaria treatment. The SMART study, currently ongoing, to look at the current phenotypic presentations of severe or complicated malaria, and the famous AquaMat study. Using data to improve clinical care, you would need some supporting staff, for which we have underestimated and overlooked. You would need research collaborators as well as assistants. The house officer, the medical assistant, the medical officer, the residents, the junior senior resident consultants are usually not in the position to collect this data that we wanted to inform decision. So we must pay attention to this category of individuals who are required to make sure that we collect the data at the right time, and it's accurate and it's credible. And the research coordinators and the researchers should be key positions that we must be creating in the departments to be able to do that for us. We need data managers and statisticians. And in advanced and progressive areas, these roles are there in every department, and they are functioning on a 24-hour clock as the data is being generated. And so our next area of focus should be building the human resource that support the generation of data to use to improve clinical care. Otherwise, always we would be going back for 5-10 years data, which may not be telling us what is happening currently. We need those who would analyze as well as report for us to go and edit the report. Now, we are currently in that mode where you are the generator, you are the statistician, you are the analyzer, you are the reporter, you are the disseminator. You cannot do that effectively or efficiently. And therefore, as we want to improve patient care by the use of data, we must pay attention to this category of staff. Now, I've mentioned these already, some of the practical research work that is informing clinical care in the PEU. We have the pneumonia, we have the typhoid, we have the complicated malaria, and we have the rotavirus and the hip going on. Data that has come out from the PEU. As we move to the PEU, over a period of time, there was the need to look at what it is that, so there was 2000 to 2010 data, and we saw these changes in our data in terms of mortality. Again, this was last 2 years where hospitalization among children with sickle cell enrolled in the Sparkle network. And Professor Ellis mention of networking to be able to collect the data to make informed decision was one of the research work that has come out from the sickle cell, from the department. Retrospective review of empyema and parapneumonic effusion in hospitalized children in Ghana, published in last month's journal of the. And these are the data that we analyze, we publish, we disseminate, and we use to inform critical care. Again, as we see, our sickle cell is our largest longitudinal cohort in the department. We have a lot to say about them, and their data comes out almost every day, both retrospective and even continuous. Again, if you do not measure, you cannot count it. Intussusception is one of the diseases that follows rotavirus introduction, and some vaccines were withdrawn because it was found out that the vaccine was strongly associated with intussusception. And so since that episodes that led to the withdrawal of the vaccines in the US, in Ghana, when all the rotavirus vaccines were introduced, we are doing surveillance, and we've been doing this surveillance for the last 10 to 14 years for WHO, Ghana Health Service, and Ministry of Health. And this is one of the publications, and it's coming from us, it's coming from Kwalibu, and it's coming from other centers in Ghana. Again, we used to give quinine in the management of malaria across the world. Now, the change in policy was through a clinical research that was done in the Southeastern Asia as well as in Africa. In Africa, Ghana participated in this study, and our pediatric emergency unit was one of the clinical trial sites. And at the end of the study, it came out that artesunate reduces mortality for around 20% in children with complicated malaria. And therefore, there was the need for a global change in policy. And our pediatric emergency unit, that is 20 years old now that we're celebrating, contributed to data, participated in research to develop or to come out with these major worldwide conclusions. And I think the department needs to, and it's always been mentioned anywhere when this Aquamat study was in a very difficult study if you don't have the men. And I would want to mention people like Dr. Bray, Dr. Silverkin, who were the key persons in the emergency unit who participated in this global research that made WHO change policy. And since this policy also changed, when we were house officers, medical officers, on the average, you see 25 malaria cases on the pediatric ward in B4 and B5. Now, within a week, you will be lucky to see 2 or 1 case of complicated malaria in the emergency unit. Malaria complications has gone down. There are several factors, but it's also contributing to the tools that were deployed and we were a part in it. Meaning that collecting data that is credible and using it to inform decisions, you would see real results. Again, Dr. Enemel and his team on every year conduct a point prevalence on antibiotic use across the whole hospital. And it's being published to find out how antibiotics are used within the hospital, and PU is part of this data generation. Again, you would want to know what is causing what mortality within the first 24 hours of admissions. We have conducted studies in that. And so you would see that the unit and the data that is required is very important. Now, what are our strengths and our weaknesses going forward next 2025 when we come to stand here on another research day? Obviously, the patients are available. We have trained staff. Currently, we even have the electronic medical record system to collect the data. So our data that is being collected with the medical electronic system, we, the residents, specialists, most residents, we should make sure that we are getting the right information into the electronic database. So we have very good strengths. Weaknesses: the non-systematic data collection, lack of standardization, challenges in contemporaneous data use, as well as weak application of the data. That is where I'm saying that the data is there, we don't have the analysis, we don't have the result report, and it's there and there and there, and sometimes we even forget about it. What are our opportunities? Once we do it, we have the evidence-based medicine to improve our care. We can involve in longitudinal trials like we've done with the Aquamat and collaborate with other networks, because when you have data, then your networks becomes stronger and people are attracted to people. When you don't have data, they think you are not even serious. Then the threats is that our clinical staff, especially the young ones, are usually not available, and sometimes we have several focus that we can also tune and become a good source for credible data, for data that can be used to inform care. The next steps would be: 1, we have to discuss as a department which direction we would want to go. Develop the gaps in the knowledge, develop the protocols that we would want to use to collect the data, identify the resources that we require, as well as train the staff that would collect the data. I thank you for this presentation. To this, if you look at the document that you have, you realize that individuals are presenting tons of information, of data that has been analyzed, that is being presented in an abstract today and even part yesterday. Please pay attention, read them. Those that you are interested, find the authors, discuss with them, and the dissemination and the discussions starts there. The change in policy and the improvement in care also starts at the one-on-one discussions with what individuals have found. What we usually see is that when we hit the break time, we all go out and we all come in, and the posters will be hanging there. We will not watch it. Please at least read 2 posters minimum before you go. Interact with those people who have hoisted their posters there, and let us have a very good program this day. Thank you very much.
Thank you very much, Professor Daniel Anson, the former Dean of KSMD. All right. I want to acknowledge Dr. Jikwa Planju. She has been one of the major founding building blocks of child health in Confanoche, and then Department of Child Health in KSMD. And she's a teacher to all of us who are all here 20 years post PEU. Yeah. So can we acknowledge her again? All right. Professor Enchikusi, we cannot let you be sitting here and not say even something for 1 minute to us as the current dean of KSMD. We are all under him. I just looked at him, I'm like, yes, even though we are want for time, I need to call him because my promotion will be going very soon, isn't it? So I also have ulterior motives. But, I mean, all protocols observed. I want us to call in the current dean of KSMD just to share a few thoughts with us, please.
Thank you very much. I think you realized that I was running away, so you needed to keep me here. Thank you very much, Eno, and thank you, organizers of this program, for inviting me. Mr. Chairman, I want to stand on the existing protocols and proceed. Yeah. So I stand before you today with a profound sense of pride and excitement in welcoming you to the Pediatric Conference and the Child Health Research Day at our esteemed medical school. A lot has been said already, but I want to reiterate that this day is not just a mere event. It's a testament to our unwavering commitment to advancing the field of pediatric medicine, particularly in the realm of pediatric emergencies. As the dean of our medical school, I'm honored to address such a distinguished audience of researchers, clinicians, and students who are at the forefront of exploring new horizons in child health. Today, we come together not only to showcase our collective achievements, but also to renew our dedication to understanding and addressing the unique challenges posed by pediatric emergencies. Personally, I'm involved in pediatric emergencies as an anesthesiologist. And if I want to share my experience with pediatric emergencies, we will not leave. So I'll just put my experience aside. Mr. Chairman, before I continue, allow me to acknowledge two individuals whom I have known to be passionate about pediatric emergencies. Professor Aduyobo, is he here? And Dr. Justice Silverkin. As far as I'm concerned, I think it was during the tenure of Professor Aduyobo that the Pediatric Emergency Unit was established. Let us give Prof a round of applause. Pediatric emergencies demand a special kind of expertise. As Professor Eliso-Sudabo said, it's not for house officers. I've been in my office when a house officer has rushed to me around 9 p.m. on a Friday asking me to come and help, either with the airway or with vascular access. And I'm like, where is your resident? Where is the consultant? But you see, as I said, pediatric emergency demand a special kind of expertise, a blend of compassion and knowledge and swift action. And because of that, you just have to get down and save a situation. The stakes are high, and the impact of our work in this field resonates through families, communities, and society as a whole. Our commitment to research in pediatric emergencies is not just an academic pursuit. It is a solemn responsibility to ensure that every child, regardless of circumstances, receives the best possible care. Research in pediatric emergencies is a journey that begins with a question. I think Professor Anson has told us already. And that question leads us down to a path of discovery. And each study, each trial, each piece of new knowledge contributes to a mosaic that shapes the future of emergency care of our children. It's a journey where the destination is not just academic recognition, but more importantly, the improved well-being and survival of the most vulnerable members of our society. The academic papers to be presented today reflect the dedication and hard work of our doctors, from understanding the unique physiological responses of children to emergencies, to developing innovative interventions and redefining protocols. And each endeavor adds a brick to the foundation of evidence-based emergency pediatric medicine. Colleagues, beyond the numbers, beyond the statistics and research methodologies, let us not forget the faces behind the data. And these are the children and their families. It is for them that we toil, that we delve into the intricacies of pediatric emergencies. Our research has the power to turn despair into hope, fear into confidence, and vulnerability into resilience. As we witness the presentations today, let us not only acknowledge the achievements, but also the challenges that lie ahead. Pediatric emergencies are dynamic, and our research must evolve to keep pace. Collaboration, innovation, and a commitment to continuous learning will be our guiding principles as we navigate the uncharted territories of pediatric emergency medicine. In concluding, I would like to express my deepest gratitude to the head of department, the departmental research team, faculty, and students who have dedicated their time and expertise to advance the cause of pediatric emergency research. Your work is not only contributing to the academic prestige of our school, but more importantly, shaping the future of healthcare for generations to come. Let us continue this journey with passion, purpose, and the unwavering belief that our efforts today will create a healthier, safer tomorrow for our children. I thank you all for your participation. Enjoy the rest of the conference, and God bless you. Thank you. Thank you.
Thank you, current Dean, KSMD, Professor Intrikusi. God bless you. We are just about to start. The first session. Dr. Tinkran is not here. He's the regional director, Ashanti region, but he has a representative, Dr. Emmanuel. And Dr. Emmanuel, can you just come and say something for 1 minute whilst we start the first session? So, participants, presenters for first session, get ready. We are going to mention your name. Our chairperson is also ready. We are just about to start, please.
Thank you very much. Professor Chair, let me stand on existing protocol since I've been given just a minute. But I cannot sit without joining my senior colleague, Dr. Emmanuel Chiremanteng, to continue to pay glowing tribute to our teachers for what you've done in the lives of many. We continue to celebrate you. I bring you greetings from the Regional Health Directorate, particularly my Regional Director of Health Services, Dr. Emmanuel Tinkran. In fact, he would have loved to be here, but the Ghana Health Service is holding its maiden Excellence Awards, which was done yesterday, and he had to be there. So that's why he's not here today. The Directorate of Child Health and CAT and the School of Medicine and Dentistry, KNUST, have led in the provision of quality healthcare for children in the Ashanti region and the entire northern sector of Ghana. Undoubtedly, this has contributed to the progress made towards achieving the SDG 3, which is to ensure good health and promote well-being, with special focus on the survival of children. And more importantly, as we've heard already, the Pediatric Emergency Unit of CAT has played a sterling leadership role in providing emergency care for children referred to the hospital since its creation 2 decades ago. The theme for this year's conference, Ensuring Excellence in Emergency Pediatric Care, 20 years on, is very apt. The Regional Health Directorate would continue to collaborate and effectively engage KNUST and CAT as a strategic partner to deliver quality health care to the children in the region. We are also open to collaborate in the area of operational research that will translate into policy implementation. And so finally, you have the assurances of the highest order from the Ghana Health Service and the Regional Health Directorate. And we wish you a very successful conference. God bless you all. Thank you very much.
Thank you very much, Dr. Emmanuel Tebu. We move into our scientific session with the first session, after which we'll go for a coffee break. Before we start the first session, we would like to introduce our judges. Please, if I call you, please kindly move to the table on the right for us, if that's okay. The table on the right. And the presenters will also move to the table on the left. Okay. Our chair for this session, with a grand round of applause, is Professor Jocelyn Dube, who is the immediate past Vice Dean of SMD. Please give me a round of applause as he comes and joins us. Prof. Dube, please kindly move to the table on the right. We have 2 judges. We have Professor Stephen Sappho, the current Vice Dean of SMD, with a hand of applause. and Dr. Alex Owusu Ofori, the head of Department of Clinical Microbiology. And our presenters. Our first presenter is Dr. Naomi Diane Ajete, our fellow in training. Second presenter, one of our final year residents, Dr. Ekwa Petseba Afo. And our final presenter will be Dr. Betsy Nkansa Osei Mensa, who is also celebrating her birthday. Happy birthday.
Good morning. A few ground rules. An abstract means summary. So you are given 10 minutes. If you exceed the 10 minutes, Washe and myself, we are very nice people, but we will deduct marks. So please make sure you keep to the 10 minutes so that we can finish on time. I think we want to leave. We both have meetings around 3 o'clock, so we want to see if we can keep to time. Thank you.
Thank you very much. And to our presenters, we have two lovely timekeepers, ladies in red over there, Dr. Phyllis and Dr. Justicia, who will show you when your time is 5 minutes and also 2 minutes. So if you're ready.
Okay, so one of the things is we learned from last year. We are going to have a question and answer session, but not immediately when they finish presenting. So jot down your questions, your concerns, and everything. Then afterwards, there will come a time that you can ask them those questions. Okay, so that we are far behind time. We want to catch up with a bit of time. Thank you. Naomi.
Sorry. Good morning, Mr. Chair, honorable panel of judges, ladies and gentlemen, all protocols observed. My name is Dr. Naomi Ajesi. I'll be making this presentation on behalf of the Pediatric Emergency Unit of CATH on a pilot study conducted to assess the utility of point-of-care ultrasound performed by emergency room pediatricians to diagnose pneumonia in children admitted to a tertiary hospital in Ghana. The members involved in the study have been duly acknowledged. Pneumonia is a leading cause of death in children under the age of 5 globally, and the highest burden is concentrated in countries in the sub-Saharan Africa and Southern Asia regions. In Ghana, it's been reported that over 4,000 children die annually from pneumonia, children under the age of 5. Contributing to this high burden is the problem of limited resources in these regions, limited access to effective interventions needed for prompt diagnosis in children presenting with pneumonia, including the access to diagnostic tools like chest x-ray and other facilities. So these problems contribute to the poor outcomes, including death. Newer interventions are emerging and becoming available, one of which is the point-of-care ultrasound. That is bedside diagnosis of pneumonia and its complications. It has the advantage of being able to be performed at the bedside and also to be repeated severally to monitor progress, as opposed to chest x-ray, which is limited because of the risk of excess exposure to ionizing radiation. However, pediatricians will need adequate training to be able to effectively and efficiently use this diagnostic tool at the bedside. The rationale for this study was based on the fact that currently there are no reports on the utility of this bedside diagnostic tool, the bedside ultrasound, in the diagnosis of pneumonia in children in Ghana. So with this study, the aim was to assess the utility of POCUS as a bedside ultrasound performed by pediatricians at the bedside as a diagnostic tool in children admitted with pneumonia at cath. Our primary outcome was to determine the number of children with chest x-ray defined pneumonia who are able to be confirmed on ultrasound performed by the pediatrician in the emergency room. So we sought ethical approval prior to the start of the study. It was a prospective study, a pilot study conducted, and over a period of 6 months, we recruited children. There was a sequential recruitment of children between the age of 2 months and 13 years who presented with a diagnosis of pneumonia. Children with chronic lung disease, congenital heart disease, and nosocomial infections were excluded. Informed consent was obtained from their legal caregivers, and the diagnosis of pneumonia was based on the WHO criteria for pneumonia and severe pneumonia. Patients had chest x-rays done, and it was reported by 2 senior radiologists. And then also an ultrasound was performed by both a pediatrician and then a radiologist. Prior to the start of the study, the pediatricians were trained and then retrained in the use of the ultrasound. The MindRay DC30 ultrasound machine was used as shown in this slide. And then we employed a 12-point lung ultrasound exam, examining 6 regions on each side of the chest. So some of the measurements that were recorded included features suggesting a normal pattern, such as lung sliding, presence of A lines, or the absence of B lines, or less than 3 B lines per field. There's patterns that suggested pneumonia included presence of B lines, such as focal or multiple confluent B lines. Features suggesting consolidation like hepatization, and then air bronchograms, as well as picking up pleural effusion, evidenced by presence of anechoic and hypoechoic regions between the visceral and parietal pleura. Data was captured on case report forms and then entered into REDCap. The analysis was done with Stata SE version 7. Demographic data was described in proportions, and then we calculated the sensitivity and specificity of the chest ultrasound, as well as positive and negative predictive values. Characteristics of our study participants. We recruited 80 of them were below the age of 2. 2 participants died, and then there was no difference between the sex distribution for our study participants. This table shows the 2x2, is a 2x2 contingency table comparing the ultrasound performed by the pediatrician to the chest x-ray reports from the radiologist as a gold standard. So 71 subjects were included in this analysis, having both an ultrasound being performed and x-ray being reported. The radiologist reported 41 x-rays as having pneumonia based on the presence of infiltrates, and then 30 having no pneumonia as in a normal chest x-ray. So out of the 41 reported as pneumonia, the pediatrician was able to pick 28 as pneumonia, and out of the 30 that radiologist reported as no pneumonia or normal x-ray, the pediatrician was able to pick 12 out of that. So based on this, we calculated a sensitivity of 63.8%, specificity of 40%, positive predictive value 60.9, and negative predictive value of 48 with the corresponding confidence intervals. To conclude, the point of care ultrasound is a useful tool. It can be used at the bedside to diagnose pneumonia in children admitted to hospital with pneumonia. This study demonstrated that it had good sensitivity. However, the specificity was poor. Combining with clinical features may improve the sensitivity. Our limitation was that this study is only a pilot, and then as such, the sample size was small, and it was also done in just a single center. So we recommend a further large scale to be able to make assertive conclusions from this steady. Thank you very much.
Good morning, Mr. Chair. Good morning, panel of judges, accurate timekeepers. Good morning, ladies and gentlemen. I'm Eko Baful, and I'm representing the Pediatric Critical Care Unit. And we are presenting a rare case of pulmonary embolism, which was, we saw the patients at the Pediatric Intensive Care Unit, Konfanoche Teaching Hospital. Authors are duly acknowledged as shown on the slide. Pulmonary embolism is a diagnosis which is recognized in children. We would want to talk about it because, as compared to adults, it's found that it's rare. And the incidence is not known since many of the cases go unrecognized. This morning, we'll want to throw light on the fact that pulmonary embolism in children exists so that we can identify it early enough. And also, this will help us to reduce morbidity and mortality. So we'll go on to present the case of pulmonary embolism as managed by the Pediatric Intensive Care Unit. So this is a story of a 1-year, 3-month-old female child who had no known chronic illness and was referred to us from a peripheral facility with a history of 4 days dyspnea and then a week's duration of fever as well as cough. And was managed for pneumonia at the peripheral site. However, the symptoms were not resolving, so the patient was referred to PU for further management. Upon arrival at the Pediatric Intensive Care Unit, she was found to be tachypnic and also hypoxic, with respiratory rates being above the 50s, which showed that it was above the upper limit for her age. And also the saturations were ranging between 75% to 96% on oxygen using the non-rebreather mask. And then her heart rate was 168 to 172 beats per minute. Blood pressures measured throughout the period at PU were below the 50th centile, but however within the normal range for her age and then her gender. When the child came, investigations were done, amongst which was the chest x-ray, which showed that the child had a pneumomediastinum. At the point, consult was sent to the Pediatric Intensive Care Unit as well as the cardiothoracic surgery team for a chest tube to be inserted. And we'll see the chest x-ray in the subsequent slides. The chest tube was inserted for the child as was said by the cardiothoracic team that it will be done. However, when it was done for the child, it was still seen that the child was hypoxic and required PICU care. Pediatric intensive care admitted the patient and managed on a mechanical ventilator on account of respiratory failure. When the child went to the pediatric intensive care unit, saturations appreciated from 75% to 98% on day 1. However, after spending 7 days at PICU on the mechanical ventilator, it was seen that the child's saturation were dropping from 8 to manage the child appropriately. So a suspicion of pulmonary embolism was made, and then we went further to do a CT pulmonary angiogram, which revealed a bilateral pulmonary embolism when the CT was done. Also, we did a bronchial alveolar lavage culture, which isolated alpha hemolytic streptococcus, which was the cause of the infection in the child. So this is the chest x-ray showing the pneumomediastinum, which we were talking about earlier when the child came to PU. And also the bilateral pulmonary embolism, which we saw with the CT pulmonary angiogram. With that, we reviewed literature to support what we had found, and we saw that clinical presentation of pulmonary embolism in the pediatric population was present. When present, it's usually not properly distinguished from other causes of respiratory distress, and as a result of that, we normally do not recognize it. Bach et al. Did a study where they reviewed patients, autopsies were done, and they realized that about 50% of the children with pulmonary embolism had signs prior to their death. However, the diagnosis was only considered in a third of this percentage. With our patient, we realized that she had respiratory distress, which was consistent with lower respiratory tract infection and also acute respiratory distress syndrome, but refractory to the usual management which we had implemented. The typical shortness of breath, the pleuritic chest pain, the cough, and then the syncope were absent in the patient, but eventually her diagnosis was revealed with a CT pulmonary angiogram. Chap et al. Reported 3 factors when he also did a study concerning pulmonary embolism, and among the 3 factors which he recognized, infection was identified to be one. And in our patient, we also identified that the patient had an infection, and then the cause of the infection was the alpha hemolytic streptococcus pneumonia, which was cultured or isolated when we sent the sample. So for children, the classical symptoms which you would pick up would be that of dyspnea, hemoptysis, but if the emboli is small, it may be inconspicuous and may mimic other diseases. Most infants, as we all know, do not vocalize, so then they won't be able to complain of chest pains. But their excellent cardiopulmonary reserve may also understate the hemodynamic effects of a voluminous pulmonary embolism. So other signs reported in the literature which we reviewed indicated the unexplained persistent tachypnea, which we saw in the case of our child. And then also you could have cyanosis in some other patients as well. So going forward, we would want everybody to think of pulmonary embolism when you have patients coming to you and then they have these symptoms as mentioned earlier. And in the case of our child, unfortunately, a day after the diagnosis was made, the child passed. However, we were able to implement treatment for the child. We started the child on low molecular weight heparin. Since as of now, we do not have specific treatment algorithms for managing pulmonary embolism in children. But initial therapies with the low molecular weight heparin has been identified to be beneficial to patients, as well as unfractionated heparin, and then recombinant tissue plasmogen activator. So in conclusion, pediatric critical care team would want everybody to know that pulmonary embolism is rare in children, reason being that we do not identify them early, and then they do mimic other causes of respiratory distress. So going forward, when we see patients, we should have a high index of suspicion of pulmonary embolism. Thank you.
Can we have our third and last speaker for this session? I think you are doing very well with the time. That demonstrates your respect for time as evidence of being critical care and emergency care doctors.
Good morning. I'm Betty Cancer Simmons, a resident. With all protocols observed, I stand on behalf of MBU, and our research was on assessing level of communication between healthcare providers and primary caregivers in the mother and baby unit at the Comfort Teaching Hospital. Communication is an important tool that we use in our day-to-day activity, and its use in the healthcare center is of no exemption, in that when you're in the consulting room, a patient enters, before you do your physical examination or request for any investigations, you need to take history from the mother or the caregiver, and this is very important. So it's defined as the transfer of information from one person to another. And I'll be quick to add that at the end of the day, there should be a positive feedback or an appropriate feedback. So there's a link between an effective communication in the healthcare setting and how the importance of the outcome, cannot be overemphasized. In that, according to Ferranda et al. 2016, they found that a lack of effective communication in the healthcare setting has been found to result in delayed treatment, medication error, misdiagnosis, and even to some extent, death. So it's on this basis that we stand here to, our study sought to assess the level of communication, the source of information, and how satisfied our caregivers were at the unit. So for methodology, data was collected using an open and closed-ended questionnaire from the caregivers who had their babies at the unit within the period of 9th to 13th of October 2013. And the study has assessed the socioeconomic status, communication level, and how satisfied our caregivers were at the unit. And the data was analyzed using descriptive statistics. For results and discussion, we found out that 99%, that's 9 out of every 10 caregiver, were the mothers themselves. And this is very important in communication because it's been found out that when information is being moved from one person to the another, let's say Kofi is a boy, before it gets to point D, the history or the information are changed to the boy is Kofi, which I believe is never the same. Yeah, and most of them had some form of formal education, which is very important. Also, 73.3% were aware of their diagnosis. And however, only 66% had their diagnosis, which matched with what was in their clinical diagnosis. So this brings to bear some communication barriers, meaning maybe the mothers did not understand whatever that they were being told. And even though communication was going on, about a quarter had concerns. And it's very unfortunate that almost 40% could not express their concerns. So this is very important because communication is not all about verbal or speech. We should pay attention to non-verbal cues, the facial expression of the caregivers, their postures, so that we need to address their issues. And at the end of the day, they will be satisfied with their care. So in all, even though there is a gap in our communication, 83% were satisfied with our communication and the care that we meant out to them on the unit. So in conclusion, there is good communication efficacy at the unit, but as is always said, there is more room for improvement. And this would help increase adherence to treatment, improve healthcare outcomes, increase job satisfaction. At the end of the day, we as a healthcare care workers, our stress is reduced. So with recommendation, there's a need for training programs with the use of standardized tools, such as the spike and the rest. And also, apart from training, there should be stimulation. So we do this, we go through the process so that we know that effective, so that we know that the healthcare personnel are grasping whatever is being taught. Yeah, so these are my references. Thank you, acknowledgements. Thank you for your audience.
Thank you very much.
Please stop.
Thank you very much, the three speakers. Every time we write a proposal, we always state that we shall have dissemination of the findings. I'm sure right now we are at the point where we are disseminating our findings. Many research findings never get disseminated. So we are doing that right now. What is going to happen next is that we are having a speed transmission. Everything's happening very rapidly. So we want to take the next three speakers before we break. I hope you're okay with that. Yeah.
All right. So the next three speakers is going to be Dr. Sandra Kwarteng herself, and Miss Eugenia Osei, and then Prof. Samson Entry. Wow, that's a heavy delegation. That's a heavy delegation. So, I mean, to keep up with everything, everybody is going less than 10 minutes, so just keep up with that too, please. HOD. Okay, so it's going to be started by Dr. Mrs. Sandra Kwarteng. Sandra.
Good morning, and all protocols observed. So I'm speaking on using sputum induction to confirm diagnosis of tuberculosis in hospitalized children. Globally, the burden of tuberculosis in young children remains high. Nearly 1 million children have tuberculosis. In Ghana, a projected 2,400 new cases of tuberculosis occur in children annually. The greatest burden of childhood tuberculosis is in lower middle income countries. There are challenges with diagnosis and confirmation of tuberculosis in children, especially the microbial confirmation. Mostly, tuberculosis is diagnosed clinically in children. So the greatest case detection failure occurs in children. Sputum induction is a procedure that has been used severally. So in South Africa, in Botswana, in Uganda, there are reports to show that sputum induction samples can be used to help improve diagnosis of tuberculosis in children. So, and especially the induced sputum sample can be used for gene expert testing. So for this study, we aimed to determine whether there's a possibility of using induced sputum samples obtained from children with presumed tuberculosis to help the microbial confirmation, because currently there are no reports on use of sputum induction samples to confirm tuberculosis in Ghanaian children. Our research question was that among children with presumed tuberculosis admitted to Komfanoche Teaching Hospital, could sputum induction be used as a method to obtain lower airway samples to help bacteriological testing for tuberculosis? We hypothesized that if we are able to obtain induced sputum samples, we may be able to improve bacteriological confirmation of tuberculosis in children by about 10%. So our method, it was a prospective cross-sectional study, which was carried out from January to June 2022, I beg your pardon. Children 3 months to 14 years admitted to Komfanoche Teaching Hospital with presumed tuberculosis were included in the study. We excluded all children who had already been initiated on tuberculosis treatment. We obtained ethical approval from CATH IRB and from KNUST IRB. All data obtained was entered into REDCap and exported to Stata version 16 for analysis. We took information such as socio-demographic characteristics, a bit of medical history. We documented mode of presentation. We examined the children and also did the laboratory analysis. So we in all recruited 144 children, and for the children we recruited, you would see that 68% of them using gene expert tested positive, and predominantly they were children younger than 5 years. The other significant thing is that the children, their parents reported that they lived in formal settings. Also, we had both children who were malnourished and children who had normal nutrition. Other significant finding, which was related to testing positive for gene experts, were children whose parents reported that the children had come into contact with people who had chronic cough, or persons, or some of the children also had been exposed to antibiotics recently. So that means that they had gone to a health facility and had been treated recently for, let's say, pneumonia or something like that. The other significant finding in relation to testing positive for gene expert was having retroviral infection. Lastly, we also found significant association between testing positive on gene expect and presenting with wheeze of prolonged duration, that is more than 2 weeks. Among the children whose gene expects were positive, 16 of them had RIF resistance on LPA testing. That's the feather testing for resistance. So we conclude that there's a high burden of tuberculosis in children younger than 5 years. We also conclude that induced sputum samples can be used in the Ghanaian setting to support microbial confirmation of children with presumed tuberculosis, just as has been reported in other countries. We also want to highlight that history of contact with a person with chronic cough is still relevant when you are dealing with children who could possibly have tuberculosis. Being HIV positive is also significant. Children who present to our facilities with prolonged period of wheezing, we should consider tuberculosis. This is a one-center study, and that's what was our limitation. However, we still found it useful as a first point in testing in the Ghanaian setting. And we recommend that further large-scale studies should be conducted in similar populations in other centers. I want to acknowledge that this study was conducted with funding from the KNUST Research Fund, support from the National Tuberculosis Control Program, and the Kumasi Center for Collaborative Research. Thank you very much. These are my references.
Thank you very much, second speaker. Our second speaker for this session is from the nursing unit. And we are very glad to demonstrate to the world that the nurses are participating in our research. Child health is an all-inclusive department, so.
Good morning. All protocols observed. The title, I'm Eugene Osei. The title of the abstract is Safety and Yield of Sputum Induction for Diagnosis of Pulmonary Tuberculosis in Children in Tertiary Hospital in Ghana. Various authors have been acknowledged. 2023 tuberculosis report, global report, it's saying that currently there are 10 million cases of tuberculosis worldwide, and then 11% of them are children younger than 14 years. And because children are unable to give readily available, good quality sputum for microbial testing, there's high failure in detecting this diagnosis in children. Therefore, they need to do the sputum induction. Sputum induction technique is a non-invasive method used to obtain lower airway samples. It involves nebulization with 3 to 5% hypertonic saline and salbutamol whilst monitoring these patients. So after the nebulization, these children, the older ones, are allowed to cough up, and if they are unable to, then we do the suctioning. Several studies have shown sputum induction is safe, well-tolerated method to obtain quality samples if all the needed precautions are taken for both the patient and then the health worker who is to undertake the procedure. Why the study was conducted, currently there are no studies that have described the safety and usefulness of the sputum induction procedure in children. So we investigated the safety of the sputum induction procedure in Ghanaian children admitted to the Pediatric Emergency Unit of Konfanochi Teaching Hospital with presumed tuberculosis. The study was a prospective cross-sectional one. It took 6 months from January to June 2022. Ethical approval received from CAT Institutional Review Board. Children 3 months to 14 years were included in the study with presumed tuberculosis, and those with presence of hypoxia, wheezing, severe cyanosis, and those already being managed for tuberculosis were excluded. Children older than 8 years gave their assent, with their parents giving their informed consent. There was clinical examination before the procedure, so with this we assessed the respiratory rate, heart rate, oxygen saturation, presence of wheezing, and diagnosis. These children were fasted for at least 4 hours before the procedure. And then during the procedure too, we monitor for signs of deterioration, wheezing, cyanosis, and bronchospasm. And those who had hypoxia, if we give supplementary oxygen and they're able to increase their saturation more than 92%, the procedure was carried on. The first table gives us the demographic anthropometric characteristics of the patient. And in total, we sampled 144 patients, and then more than almost half of them were less than 2 years. And with this table too, we can also see that both the well-nourished and the undernourished were included in the study. Safety of induced putum procedure based on clinical examination. Out of the 144 patients that we sampled, 98 were positive and 46 were negative. So we did this assessment before and after the procedure. We assessed the temperature, respiratory rate, pulse, and oxygen saturation. And then from the table, we can see that both the before parameters and then the after parameters are the same, almost the same, with no significant change, clearly indicating that the procedure was very safe. The third table also gives us the clinical parameters. For central cyanosis, stridor, and wheezing, we realized that 3 patients came in with central cyanosis, but before the procedure and after the procedure, these signs were not there, so the reason why we're able to do the procedure. But then there are 3 patients out of the 144 who did not come with epistaxis. And before the procedure too, there was no epistaxis, but at the end of the day, they had epistaxis. But this one got resolved within the 30 minutes that we had to assess without any specialized treatment. In conclusion, I want to say that putum induction is safe and well tolerated in the pediatric population. It provides a high yield for microbial confirmation for children with presumed tuberculosis. And it is an important diagnostic tool for childhood tuberculosis. Thank you.
So I'm coming to you again. Mine is a message that the father is giving to the children. So take notes. So I'm not their 10 minutes, and I'm not also underscore this thing.
So this time, Prof. Entry is not speaking as an HOD. He's speaking as one of the research scientists in the department. Okay. And he's not being scored like the others because he's not spending the same amount of time. So he has 15 minutes for a different message. So, research scientist.
Research scientist. So, and I'm happy we have a lot of people from our districts. This is very passionate. What I'm presenting are just case series of urinary schistosomiasis. And I don't know whether you see schistosomiasis in your places. So this case series I'm presenting was first published in the Ghana Medical Journal in 2014. So it has been there for a very long time. And that is the reference. You can actually access it and read it. But I just want to make a point. So we know areas that are endemic for urinary schistosomiasis, commonly where we have large water bodies associated with damming, and the people who also like clean drinking waters. So we know that. I'm sure once anybody comes urine schisto, or you reach out for your pen, praziquantel, 40 milligram per kilo, start. Bam. That is what we do. But there's a message. And the message is that there are a lot of devastation that it causes on the urinary tract that people are not aware of. And that's the essence of my message. And that is why I'm saying the unacknowledged impact of schisto on the urinary tract. And these 5 cases I'm presenting, so just to highlight the unacknowledged impact to healthcare practitioners. A bit of pathophysiology. When somebody gets schisto, the egg is the problem. The egg. there's a strong host response to the egg, wherever the egg is found. And the response leads to granulomatous inflammation, forming commonly the eggs are in the bladder, in the venous of the bladder, or the ureters. So these granulomatous lesions form there, and the result is that you may have bladder outlet obstruction, or you get hydronephrosis, hydrouretus. And these people do not think about them. And of course, into adulthood, it can actually lead to cancer of the bladder. So it's not just praziquantel. So this is the case report over 2 years. Interestingly, probably their mass deworming may be working, not with mebendazole. Probably they also do cysto deworming. May be working. I haven't seen some for some time, but when I came from training, these cases were recorded from 2010 to 2012. But I haven't seen some for a long time in the world since that time. And it's not pleasant what I am listening. So I'm presenting 5 cases. Actually, I saw 8 cases of schistosomiasis, but 5 had impact on the urinary tract. And the sad thing is that 2 of them died. 2 underwent surgery, and they were being followed up. I haven't seen them for a long time. I don't know what has happened to them. And interestingly, one person he underwent spontaneous recovery. That was a very interesting case. And so, schistosomiasis from the pathology that he had on the urinary tract. And so, once can actually kill you. That's the point I want to stress. I keep on telling mothers that when you see cobra coming, you are running away, cobra, cobra. But that mosquito on the wall, on that wall there, can send your child to the grave. That is why you must take every step to kill mosquitoes and use net and things like that. So cysto, when you see it, it can actually lead to the death of somebody. So that is what I'm presenting. So the first case, look at them. This is 7 years old. He was admitted to our PEU. He came with congestive cardiac failure and hypertension. 7 years. This was the BP. And he comes from Akosombo. He has lived there for greater part of the time. Remember, I told you the risk factors, diamond, where we have diamond. So that was not surprising. Okay? The urine dipstick, that was done show protein and blood. So when you see protein and blood, it's not just glomerulonephritis. It is important for you to go ahead and do urine microscopy. And for this child, we saw X of S hematobium in the urine. So once I had that in mind, well, HB was low, MCV very low, creatinine was what? 430. And he had E. coli in the urine. So he had come with a heart failure. We know it. So heart was big, and they have medicine. We have E. coli isolated. Once you see ordinary, anybody with a kidney disease, as part of evaluation, just do ultrasound. Not so expensive. It doesn't cause a lot of damage. So do that. Because there may be some underlying conditions that you think that, oh, the person came with just nephrotism or whatever, but he may have some underlying condition. So because of the cysto, once you see cysto, consider doing ultrasound throughout obstructive uropathy. Even if at the point you do it and it's normal, schedule the person for follow-up ultrasound. Because this fibrosis takes some time to develop. So this child came with congestive cardiac failure. We treated, but I have seen cysto in there, so I was worried that probably the child may have this. We did ultrasound, and he had hydroureteronephrosis, which means that it was a lower urinary tract obstruction, because the ureters were also dilated and taking bladder wall. So I was very convinced that this is because of the cysto. And of course, because it has come with heart failure, we have to manage the heart failure, treat the hypertension, and usually praziquantel will go. Those of you who have been around for some time, one specialist came from America. He was one of us, actually. And he was noted for praziquantel. Anybody who had renal failure, praziquantel. And you probably, that was what was taught in America. Then in for Africa, all the renal failure cysto. He has some points that renal failure may be a cysto. And so take note of that. So we had to put in the catheter to relieve the obstruction. Why catheter? The bladder was also taken, and I'm saying cysto can affect your bladder outlet, so it can give you a low. But commonly, it is the ureters that are also affected. And so once we did that, even without doing any other intervention, the creatinine just settled at 58. So relieving the obstruction was useful and was discharged. But I wanted to do maturation cystoureterogram to delineate where the obstruction is so that we can intervene. But when he was discharged, he didn't come. It took some time, then he came back again in a very bad state, readmitted, just to cut my story short. And things happened. The creatinine that has normalized before he went to, it has risen to 732. And all the parameters were down, were terrible. Look at phosphate, 3.6, when the normal is supposed to be 0.9, probably 1 point something. That was so high. And at that time, that's why I'm so happy. I had to fight very hard to get a pediatric urologist to treat. And since the Maku came, I think I'm having a lot of my problems solved as far as urological surgery is concerned. We don't have any distance, the adults. You'll be chasing them, they are so much focused on removing prostate. So you are worrying me. And this child, it took a very long time. They didn't do anything. When the child was almost, I said, look, we can't do this to this child. So eventually they agreed to go in. They agreed to go in. In fact, we tried to even insert the nephrostomy tube, but I think the child bled. So they went in. We couldn't do IVU because of the renal function was not resolving. So they did surgical exploration. So it was a bit late. And what they saw was a very, okay, the findings are here. Yeah, the distal ends of both ureters were markedly taken with calcifications, and the orifices were severely stenosed. So definitely it's telling you that the distal ureters were obstructed. And bladder was, taken, and they get these typical granulomas within the bladder, this thing called sandy patches. So what they did was to try and attempt to do uteric plantation, and they placed a stent, but the child died 3rd day post-op. We lost this child. The schistosomiasis he had, that I'm sure he was giving plastic quantity, that was the end. The egg is still there, the body can react. Obstructive uropathy gives you hypertension. So in combination of all that, obstructive uropathy, hypertension, or look at the BP that he came in. He had heart failure, the kidney was gone. And this child sadly died. I think that the primary disease that led to the demise of this child was the schistosomiasis. That probably was not picked up early or it was not followed up very well. Second case, 12-year-old from Nkranza. Nkranza is a bit far away from Yeji, but in Nkranza he came. He presented with a seizure disorder. Yesterday, they defined seizure disorder to us, where he was convulsing. It's one of those things. Come on. He has presented to a local hospital with fever, headache, and BP was high. You can see that. And baseline labs, creatinine was very high, as you can see. And the urine, once again, schisto. So when you do dipstick, you see blood. But please, do the macroscopy. So we saw schisto. And when I saw schisto, you need to do ultrasound. So we did ultrasound, and definitely you also had hydroureteric nephrosis. Schisto has also blocked this thing. And scheduled nephrostomy tube, and he had a mass. This child had interest in, he is the one who had spontaneous resolution. After hydronephrosis, he had a mass in the bladder, the trachea area. And so they hadn't even planned to go and excise that mass, but he was discharged to come for follow-up. When he came for follow-up, the whole mass, in fact, when he came, the kidney function spontaneously, without even a catheter, nothing, was coming down, and the mass has reduced in size. Follow-up review, actually, the mass completely resolved, this particular child. And I read the literature, and actually it can happen like that. Sometimes it can't resolve on it, just like Takayasu arthritis. I've seen somebody who could not get any pulse, no pulse in any of the limbs. He came later, and then it has resolved completely. So this child resolved completely. He is now in secondary school. I'm sure even probably maybe entering the university now. Because the father said, keep on calling me from Yeji. We become friends. So schisto, think about obstruction. Third case, 12-year-old from Yeji. That one is schisto endemic area because of the water bodies. It came with hypertension. Once again, I told you, schisto was in it. Once you see schisto, you do ultrasound, hydroureteronephrosis. MCUG was able to do that. It shows narrowing of the posterior urethra, and I think we're able to do IVU. That also shows stenosis of the distal urethra. Always, cysto will affect the distal urethra and the bladder outlet. And hypertension resolved following treatment, blah, 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 and antibiotics. And we put in bilateral nephrostomy tubes were inserted, and I think this child survived. He survived. We didn't do. He underwent uterus, and okay, repeat ultrasound, reimplantation. Yes, we did implantation, and he has survived. We are happy that he survived. The fourth case, 11-year-old, referred from a district diagnosis of chronic renal failure. He also died. He came from Suhum. Suhum is also noted for cysto. Okay, he referred to us. We couldn't do much. He came so bad. He had cysto, and he also died. So he's the second person who died at advanced stage. But the fifth case, because I've been shown that it's 5 minutes, I'm sure we are saying timing me 10 minutes. I was giving 15 minutes, but I said timing. But that's the last case. Anyway, this case is interesting. Yesterday, I presented a bit of it. It's a 12-year-old was referred from a district hospital. The child came, was 12 years, wailing, complaining of flank pain. I was teaching in Cape Coast when they called me. Once they told me this child had gone to a hospital, he was not passing urine, so all the doctor did was give IV fluid and lysis. And yesterday we learned that that's a bad practice. Assess a case differently. And once they gave that one, the child started wailing severely. So when they told me, they said, boss, the urine microscopy had cysto. As soon as I had cysto, the child was not passing urine. It's obstructive uropathy. Go and do ultrasound. And lo and behold, ultrasound confirmed bilateral hydroureteronephrosis. Very severe one. So why was the child wailing after the IV fluid and lysis? It made the hydronephrosis worse. So I just gave instruction, just go and get nephrostomy done. I was trying to get a guest picture, but it is mishapping my distance. We had bilateral nephrostomy done. The pain went down, tightening, everything became normal. He had reimplantation, and he also survived. So my story, so that child survived. My story is this. Schistosomiasis may not be benign after all. You think if you see cysto praziquante, it will not be benign after all. And so we should definitely evaluate the immune system. Do ultrasound for everybody you see cysto. Even if he hasn't got hydronephrosis at that time, so put the person on the radar, schedule a follow-up. Because sometimes it takes time, this thing takes time to develop. Let us do that. If every 6 months we are doing cysto, we'll be able to save some of these things. But I also made this recommendation, now that they are doing point of care pneumonia diagnosis. Those who do mass screening, when they go to schools, the villages and the rest, we have portable ultrasound. For me, you should also take this along. Anybody you go to endemic areas, just an ultrasound looking for hydronephrosis is not difficult at all. You just put it there, you see it. That is my recommendation. So as we live here, please, cysto is equal to praziquante, but it is beyond praziquante. Let us take note so we can save children. Thank you.
Thank you. I think turn it off. Okay, so LOC, what is the plan for the next few minutes? Thank you to all the last 6 speakers. Thank you.
We are going for a short break. One, to stretch your legs, and then to have something to eat. And the following person, please. And then we'll have a photo shoot with everybody, together with our chairperson for the day, and then all our judges and everything. So I know some of you are in a hurry. Some of you have even at the snack place already. Augustine Afol, I can see your head. Hey, we are taking a photo. Come back. All right, okay. The following person, please kindly go to LOC at the back. We need to confirm something with you guys. So if you hear your name, don't join the photo shoot yet. Just go to the back first. James Tete, is it Mana, Aaron Kwesi Nati, Samuel Frimpong Odom, Esther Anlo Ampong. We just have some few things to sort out with you guys. James Tete Mana, Aaron Kwesi Nati, Samuel Frimpong Odum, Esther Anlo Ampong. Just CLOC. Yeah. And then, this conference is a 2-day conference. We had a workshop, so we are going to get a lot of MDC points. You don't want to miss out. If you have not written your name with your MDC number, it's not your signing for your registration. There's a special form that we have your name and your MDC number so that we can enroll you and put your points, and then you can register for next year, isn't it, at MDC. So please go to the LOC table. If you have not done your MDC one, go to the table and go and do it now. The rest of us, let's go and take the picture and have something to eat. For just 10 minutes, there is for 10 minutes, I beg you. No repetition of yesterday. Thank you very much. HOD, I love you. I really love you. I really, really love you. Our presenters are going to be from hematology, Mr. Aaron Kwesi, and then from neurology,
Kanzi, and we'll be looking at the clinical profile, treatment, and outcome of epileptic spasms at Konfanoche Teaching Hospital. A 3-year retrospective review. Okay, so as a brief introduction, epileptic spasms are just a brief. Epileptic spasms are a brief proximal tonic contraction of the proximal or truncal muscles, and they are typically seen in infants and young children. And because it can be seen in children outside of the infantile period, is the reason why we are no longer saying infantile spasms and now we say epileptic spasms. And when you have the spasms occurring with hips arrhythmias and developmental regression, then you are saying the person would have West syndrome. In terms of the pathophysiology, when the immature brain is exposed to various stresses, you have increased CRH, corticotropin releasing hormone, and then that's what predisposes the child to get epileptic spasms. And this is the basis for using all the things that we use for the treatment, including corticosteroids like prednisolone, and then we also use ACTH in the treatments. Okay. In our environment, in low-resource settings like Ghana, the main challenge is that we have a very high incidence of birth asphyxia, and that's a very common cause or an etiological agent of epileptic spasms. And also, a lot of the patients will present very, very late. Even when they don't present late, sometimes clinicians are not able to recognize the features, and even they will just say, oh, the child is having startle episodes, instead of actually recognizing the various things that would make you think this child is having epileptic spasms. And this has prognostic indications because the earlier you intervene, the better the prognosis for the child. And also, cost of treatment options. ACTH is very, very expensive. Vigabatrin is very, very expensive. Not all of the patients that we come across will be able to not all of the patients that we come across will be able to spend so much money for treatment. So we tend to mostly stick with high-dose prednisolone. So our treatment options are very, very limited. Okay. So the aim of our study was to describe the clinical profile, treatment, and neurological outcome of the cases that we've seen at Konfanoche over a 3-year period. So we reviewed the electronic records of all the patients who had been diagnosed with epileptic spasms between January 2020 and August 2023. The data we collected included demography, we looked at their age, gender, we looked at their developmental profile. Is there any developmental delay? Is there regression? Only one patient that didn't have anything of that sort. EEG findings, was the EEG done at all? And if it was done, what were the findings? The etiological causes, treatments, and then also the outcomes. Then the data we exported to Microsoft Excel and then we analyzed. In terms of the results, we had 44 patients in all for this 3-year period. The median age of presentation was about 9 months, and this was much higher than studies that were conducted even in South Africa, which was about 6 months. And like I said, sometimes we recognize epileptic spasms very, very late, and that has a bearing on the eventual outcome for the patients. The interquartile range was 6 to 12 months. Developmental delay or regression was found in 88.6% of the patients. One patient did not have anything of that sort, only had the spasms. In terms of the sex distribution, most of the patients were males, and that is what has been happening in almost everywhere else. And then for the age at presentation, we've already spoken about it, but was between 7 to 9 months. You have 11 patients between 7 to 9 months. That's about a quarter of them. And then also about another quarter between 10 to 12 months presenting with epileptic spasms. So it's not even in the early infantile period that the patients are going to be presenting. A lot of them would present much, much later. Okay. For the underlying etiology, birth asphyxia for us was a major factor. Then we also had patients who had neonatal seizures. And I know a lot of us went through the groups yesterday. So neonatal seizures, whenever seizures are occurring, it predisposes the brain to a lot of injury. Some patients have structural abnormalities, some had corpus callosum regenesis, and all of those things. And then prematurity was also another risk factor. We weren't able to do a lot of tests to know other underlying causes because you can have metabolic factors, and then a few of the patients were able to afford neuroimaging, MRI, CT scans. Some had done transcranial ultrasound. So all those things need to be done in order for you to say you cannot actually find a cause. But for us, that was one of the limitations. EEG data was available for only 28% of the patients. And for the typical hips arrhythmia or the best suppression, we only found it in 64.3% of our patients. In terms of treatment, most of our patients were only treated with prednisolone. So 65.9% of our patients were treated only with prednisolone. And then for 20%, we used prednisolone with vigabatrin. And only one patient had prednisolone, vigabatrin, and ACTH. Again, vigabatrin, very, very expensive. ACTH, very, very expensive. So that was one of the limiting factors. Still, looking at the outcome, short term, 27% of our patients had complete recovery of their spasms. This one is just clinically. We didn't do another EEG to find out if it had resolved in terms of like the brain activity. And then for another 27% of the patients, there was an improvement in the spasms, but not a complete resolution. And for 20% of the patients, the spasms resolved but recurred after a short period. And for 4 of them, there was no resolution of the spasms at all. For long-term prognosis, again, because we've already stated that for the etiological causes, birth asphyxia is a cause, a lot of our patients ended up with cerebral palsy. So almost 50% of our patients had developed cerebral palsy in the long term. And for some of our patients, 16%, it evolved into other types of seizures, predominantly Lennox-Gastaut syndrome. We had 2 patients, unfortunately, passing away. And almost half of our patients, 47%, were lost to follow-up. In conclusion, for us, birth asphyxia is the most common cause, most common underlying cause of epileptic spasms in Komfo-Anokye Teaching Hospital, and steroids are the mainstay. The outcome is mixed, an early referral, and then prompt treatment is recommended. The main aim is for us to recognize that not every startle is just for noise or anything. Like, we should delve in further to know if the child is having something further that needs investigations and treatment. Thank you.
Had tertiary level education, and 11% had no formal education at all. Some had non-formal education, that was about 7.6%. For the time taken to cath, most had, it took more than an hour to get to cath, and 30 minutes to an hour was about 40.2%, and less than 30 minutes was 7.2%. So modes of transport, public transport, trotro, was most commonly used. 19% came in their own private vehicle, but 2% came by other modes, suspecting those were there by ambulance. And most lived in self-contained owned accommodation, which is very impressive, considering the fact that most had no income at all. So why did we do this? We want to know the life cycle, as we like to put it, of the antibiotics that we see people consuming all over the place. So we wanted to know who prescribes it. Sorry, the slides seem to have changed. This should have been the first one. Who do you first contact when your child has an infection? And you realize that 64% of them would consult a pharmacy. Again, I infer what you will, but maybe they don't want to come and delay in the hospital, and then at the end of the day, you write antibiotics anyway, so they want to cut out that middleman. And only about 5% come to the doctor first, privately, and a quarter come to the hospital. And when they get the antibiotics, do they adhere to the recommended duration? 84% said they did. And if they did not adhere to the medication, why? Well, I apologize for that not showing. Most of them said once the child feels much better, they stop. Or when the caregiver forgets, they also just stop. How do they dispose of the leftover antibiotics? Most of them do not dispose of it immediately. 90% of them dispose of it by throwing it into the rubbish, which is actually the recommended thing. You are not supposed to flush antibiotics down the toilet or pour them into the gutter. Okay, so in conclusion, the socio-demographic characteristics of study participants varied across the strata examined. Future association studies on access to antibiotics and socioeconomic factors will be needed. Thank you.
Thank you very much. We are going to take some questions and then answers from previous presenters, and that will be handled by our chairperson, please. I don't know, maybe we'll take a few and then.
Oh, okay. So thank you very much to all our presenters for a good job done. We will have okay, so maybe 5 minutes. If you have some burning questions from all the presentations this morning, please raise up your hand, introduce yourself, and go ahead.
From all the presentations, the morning presentations, any questions?
Oh, okay, all right, yes.
I have a question for Haruna, and I'm hoping it's something that was burning on your minds as well. When we are frequently told minimal change disease prevents us nephrotic syndrome, I wasn't really aware that minimal change disease also can present as steroid-resistant nephrotic syndrome. Is it possible to diagnose minimal change disease just by biopsy and not electron microscopy?
All right, thank you for the question. So, like I said, the information or the data we gathered was a spectrum, okay, from about 11 years. And I think apart from the biopsies that we're doing in Confanochi, we also had a study that was ongoing, that is the H3 study, which was ongoing. So they were doing both electron microscopy as well as the light microscopy.
Question answered. Renal team, I've seen that you are on a table. Do you want to add any more to it? Or you are good? Renal team, you are good. All right. Any more questions? Okay, good. Frame, I see your hand.
Please, I want to ask the MBU team. With your data, who collected it? Because I'm thinking that if it's a health worker, somebody working on MBU, the answers may be a bit biased. So I want to know who collected the data.
Yeah, it's true. Actually, that would be one of our limitations. But the person who presented this year, I wanted to answer it herself. Yeah. So tell us who collected it. And we know that there's definitely going to be a bias.
Okay, so it was residents and house officers and MOs on the ward. Yeah, so it's part of our limitation. Yeah. Mm-hmm.
So, like we're telling Prof. Sakoto, it's still an ongoing research. We just presented what we had for just this conference, but we are still ongoing. We have a large sample size, and we have not gotten the sample size yet. And one of our limitations is the health workers taking the questionnaire. That's one of the limitations. Yeah, it's a bit biased. Yeah, we have the bias in there. You have something to say?
To reduce the level of bias here. So just as I said, from the ward that I was taking the questionnaire, I had never reviewed patients from that ward. So they didn't know me, even though I had introduced myself that I'm a doctor on the ward. Yeah. Well,
You have no question. It's okay, but still, the bias is still there, isn't it? The mother will say that if I don't say that you communicate, you tell your colleague, isn't it?
So this is just an advice that possibly you need to get some totally different research assistant or someone to take it for you, rather than...
Yeah, I think so. Maybe the rest of the questionnaires, we will have to train research assistants, and then they will take it so that we reduce the bias. So it's even good that we presented, isn't it? Well done. Well done. Well done. All right, any more questions? Yes, please. From there, I'll just take another one and then we'll move on. We are trying to, our judges need to be at other meetings. So we are trying to finish quickly so that they can go for their other important meetings too.
So my question goes to Dr. Kanzi and team. What do you describe as the period for recovery for the infantile spasms? Is it 6 months, 1 year?
Neurology team.
Please, is it for our study? Okay, this was a retrospective study. We just collected the records. So it was difficult for us to actually say maybe over a period of 1 month, this is the outcome we are measuring. Because most of the other studies that I read through, they actually categorize it at 1 month. So in 1 month, what is the short-term outcome? So has the child recovered? Is there an improvement? Like, is there a reduction in the spasm? If it's reduced, say, from 10 to 5, if it's reduced by like half, then they call it an improvement. If it hasn't, then there's no improvement at all. But for us, it was difficult because there's also very scanty documentation on the limbs. So going through each of them is very, very difficult trying to extract this information that we're talking about. For about 2 of the patients, I actually had to take them out because you read through and then there's just one entry on the limbs and there's virtually nothing for the patient at all. So it made it difficult, and it was retrospective, so I couldn't actually get this data to say, okay, over 6 months. It wasn't uniform, so I can't say, okay, 6 months or 3 months. But for most of the other studies, I already used 1 month.
Thank you.
Dr. Hammond, do you want to add on? They have no duration. Okay. No duration.
Yeah, please, I want to find out from Dr. Pencil.
Dr. Pencil?
Yes. Like, I want to know, with the ongoing debates on the use of plastics in eating hot foods, is there any study linking it to childhood cancers? Because when we talk about the cities, that is what is going on, and there are a lot of debates on it.
So you want formally, okay, let me just give it to you. Oncology and plastics.
Well, in terms of the plastic, we know that there's a lot of debate. They will tell you not to put hot things in plastics because there are release of lots of free radicals and other things, which might be carcinogenic. But if you talk about a study, I haven't really seen one, but that postulation is there. And so if people feel, I think that at times we just need to be cautious because you don't know what genes you have and whether any of those free radicals will do anything to your genes. So it's better to sort of stay safe.
I don't know know whether Dr. Pediatric wants to say something. All right. Okay.
Still to Dr. Paintel. Please, have you considered the fact that we have more pediatricians, so we are diagnosing them more, especially in the Puno-Ahafo region? That's why we are picking up more cases instead of possibly the exposure to all those things we are talking about. Because maybe previously they were resorting to herbal preparations and they were dying without us identifying them. I think it's a good thing to look at too.
Around areas. That is why we are seeing more cases coming from different areas instead of, because you said something that in the past it was just around Kumasi and all that. But now we are getting more from, because you have lots of pediatricians
In the periphery.
yes, in many districts.
Yes. So one thing is that we have been doing lots of early warning sign trainings. So that is, so even all the health workers, up till public health nurses, lower down at the CHIPS compound, we do lots of training all across the country. And so with that, we are expecting that we'll get even more numbers of childhood cancer cases. Currently, if we take the numbers that we see across the country, initially it was just around like 250 to 300. But currently, it's nearly around like 600 to 700 new cases every year, which is like have doubled. And that could be, the early warning signs can be one of them, the training can be one of them. So people are able to identify them and then bring them. So the other thing, all that you are saying is true. Early warning signs could be that there are other health workers there. But apart from that, we know that environmental factors also have a link, a great link to whatever happens. And so we just wanted, it's not only with the galamsey, that is what I presented, but we are trying to see whether the change in weather, because right now there is all these weather changes, ozone layer depletion, all these things happening. And so we are trying to see whether our changes in weather, reduction in the malaria and all that is having an impact. Because we can say that with those with lymphomas, that could be one of the reasons. Because at first we're seeing lots of job exits, but currently it doesn't happen. If you talk about lymphomas, very few lymphoma patients now, although we see everybody, there's very few lymphoma patients. So what in the environment is really causing that? It's not only training people to pick them up. There's something that is causing that one to happen. So it is something that we need to study and know the cause for it.
Very much. My question goes to Dr. Ajete and team. Yes. So I want to find out the level of agreement between your point of care diagnosis and pediatrician diagnosis of the pneumonia.
Thank you very much. Okay, so we didn't include that in this because we wanted to go straight to the point. So there was a comparison between the ultrasound performed by pediatricians and then compared to that performed by the radiologist. And the CAPA statistics, it showed a moderate agreement. It was substantial, 0.6. So out of the cases of pneumonia that the radiologists picked, pediatricians were able to pick about 91% of the time.
Right, thank you very much for all your questions, and thank you very much to the presenters for a good job done. So this is the end of this session. We will have another session before. Thank you all very much.
All right, thank you very much, Dr. Mrs. Planju. So for the next section, our chairperson is going to be Professor Linda Fonjo, who has been here from the morning. Let's give it up to her as she takes the chairperson's chair. And we will have 2 nursing presentation and then 2 pediatric presentation from the district. We are very happy with this year's conference because we have lots and lots of nursing presentation, and our pediatricians at the district are also showing up. So I would like to invite Miss Lucy Dapa, and then Mr. Barnabas. I saw Barnabas somewhere there. Yes, okay. And then Salamat Tebil, you're here. All right, coming all the way from, is it Brekum? Hey, controversial people. I'll leave it at this place. And then, of course, our indefatigable Dr. Yaduma Jumofoku, where is she? All right. Okay. Okay, so we will start whilst we wait for Adoma to come. So, Lucy.
Good afternoon, everyone. I'm Lucy Dapa. All protocol observed. I'm here to present on a modified evidence practice guidelines titled The Nurse's Role in Preventing Pressure Injury for Children Immobilized While Ventilated. Pressure injury prevention and the integrity of the skin maintenance is usually overlooked in the pediatric population, especially among the critically ill children. Faced with many urgent priorities in the pediatric intensive care unit, nurses in a busy PICU tend to regard pressure injury prevention as the least aspect importance of care. The main causes of pressure injury formation is the prolonged immobility as a result of the high acuity of these children, and then the kind of interventions and therapy these children receive in the PICU environment. Again, their tissue has the ability to withstand prolonged pressure due to the intensity, leading to these ventilated children to develop high risk of preventing pressure injury. And with these factors, they are grouped into 2. The first one is the patient-related factors, and we know these children have skin immaturity, and the critically ill children also have poor tissue perfusion and oxygenation. When it comes to their nutritional status, it is compromised. And this also depends on the severity of individual children, as in the kind of sickness that they bring to the PICU environment. With the healthcare-related factors, it is the immobility of these sedatives, such as the midazolam, and the paralytics, such as the saxmetoniums, due to the invasive ventilations that we give to these children. Again, the friction and shears caused by the improper positioning that we position these babies on their beds. And from the pressure injuries from the medical devices, such as the ECG leads, the SAT probes, and the ventilated circuits. This modified evidence-based practice guideline is intended to be implemented in the pediatric intensive unit, Konfanochi, Kumasi, Ghana, focusing on ventilated children from 3 months to 13 years, because this is the population PICU usually admit. The aim is to develop a modified evidence-based practice guideline focusing on the prevention of pressure injury in these ventilated children, again, to maintain the integrity of their skin, and then promoting excellence nursing care in PICU. This also prevents the permanent scarring, such as the alopecia, the loss of years, as well as the psychosocial related burdens on both the parents and then the child as well. because this prolong their length of stay at the hospital, leading to infections. And also they have to, in our setting, they have to buy this medication from their pocket. So when we do this, it will prevent these burdens. According to South African guidelines of excellence, in the development of evidence-based practice guideline, you need to establish the topic, the end users, and the population. Then with the methods, you have to identify the existing evidence practice guideline. And this was done using bibliography database such as the PubMed and the CINAHL. And again, from the Royal Children's Hospital guideline, Melbourne, as well as the Google search that was used to identify these evidence-based guidelines. Then from that, it underwent screening and identification, so using the Prisma flowchart. So after that, the included practice guideline must be appraised using the ICAHI, that is the International Center for Allied Health Evidence. And appraising and existing guidelines help you to identify the quality nursing practice to optimize the best standard of practice as well. So this is how the Prisma flowchart looks like, where it included only 2 guidelines. So after appraising these guidelines, it must also go through under expert consultation. And these experts were able to identify the gaps, and then we get their views on this recommendation that are relevant and practicable to the setting, which is Pediatric Intensive Care Unit of Kumasi, Ghana. So the result, after it was evaluated, it was modified and then arranged in order of priority, with each theme of recommendation it must also be appraised using the level of evidence and grade of recommendation. Talking about level of evidence, it talks about where these evidence are obtained, such as the systematic review and randomized control trials. So most of these modified recommendations were at level 2 and 4. And level 2 is about this evidence being obtained from randomized control trials. And then that of 4 is the cohorts and the descriptive studies. With strong strength of recommendation talks about the panels, which are the experts and clinicians, are much optimistic that these recommendations outweigh that of the negative impact. So when you are done, it needs to communicate to the end users, who are mostly the nurses. So it was developed into a flow chart. So this is how this flow chart looks like for the end users. And these recommendations or the practice were divided into 2, which are the main nursing care and the supportive nursing care, where it talks about assessment, surface support, medical devices, repositioning, and then whilst you are preventing your friction and shears. Then supportive also talks about the moisture control and skin care, nutrition and hydration. And we are not leaving these families alone because they are a very good resource, so family participation as well. So to conclude, key note that nurses are supposed to know is that risk injury and skin assessment must be evaluated and completed using the Glamon modified scale. That will help you to know the best care or the plan of action that you need to give to this patient. And safety is key. Safety is very, very important. You need to ensure that the ET tube or the trachea tube are well positioned and checked before repositioning. Once you are repositioned, it must be done in 10 teams every 3 hours. And the last one talks about the provision of pediatric design pressure relieving alternative mattresses, as this one provides us the surface support, and it helps us to manage the offload from the integumentary system. Thank you very much. This is my reference.
Good afternoon. Mr. Chair, kindly permit me to stand on existing protocol to submit my research findings. My name is Barnabas Manlokia Raymond, and I work at the Pediatric Oncology Unit of Konfo-Anokye Teaching Hospital. So I'm presenting on prevalence of burnout among pediatric oncology nurses at the Konfo-Anokye Teaching Hospital. The work environment of oncology nurses is often unpleasant, and this is as a result of the complexity of cancer itself and the treatment that comes for the treatment of cancer. So you realize that this complex environment often comes with a lot of challenges, including physical, mental, and spiritual on oncology nurses. So oncology nurses ought to have a guide to be able to identify these challenges that come with it and prepare themselves appropriately to be able to deal with those challenges. Unfortunately, the Konfo-Anokye Teaching Hospital Oncology Unit do not have any document that is able to facilitate nurses to be able to identify factors that bring distress to them. So this often leads them to a lot of burnout. Burnout, which is defined as a state of emotional, physical, mental exhaustion caused by excessive, prolonged stress. Now you realize that burnouts often lead to increased depersonalization and decreased personal job satisfaction. And because of this, we decided to assess the baseline information on pediatric oncology nurses' stress, sources of burnouts for the work they do, so that we will be able to develop a supportive document that will aid pediatric oncology nurses be able to identify the source of their stress and manage them appropriately. What did we do? So annually, every year, we have supportive workshop for all oncology nurses in Konfo-Anokye Teaching Hospital. So for this year, 2013, when we held our supportive care workshop, we decided to survey them to understand the sources of their burnout so that we would develop the document to support them. So we came out with a semi-structured interview guide, a semi-structured questionnaire, and administered it to all those who participated in the workshop. So call it total population sampling. So we had 15 participants who took part in the workshop, and all of them agreed to answer the questionnaire, which we administered to them. The result was analyzed and then presented in diagram. Okay, so the first aspect of the results was the demographic layout, which was not surprisingly, as majority of the profession is dominated by ladies. So 80% of them were females and the rest were males. The most significant thing to note in this result is the number of years the respondent worked in the oncology unit. So the least person who participated in this study worked for 3 years. And that is very significant. And that is even the least. That is about 34%. Between 3 years and 5 years was about 34%. But those who worked for more than 5 years form majority of this respondent of about 66%. So what then did we found? We found that lack of logistics to work with by oncology nurses was a very key source of burnout to oncology nurses, which form 90%. Then other components, about 4 of the other components with 80% of as a source of burnout. So poor work environment, lack of motivation, heavy workload as a result of understaffing, especially at this time that we have unprecedented exodus of nurses seeking greener pastures. Late presentation of the cancer diagnosis, and then for those of us who have passed through the oncology unit, you will realize that majority of the time the people come at an advanced stage and you just look at the people and you just wonder where this is coming from. And that is a very key source of worry for the nurses who work at the oncology unit. The other ones to look at were emotional bonding with patients as well as lack of professional support. So with emotional bonding, you realize as it occurs in every acute care setting, chronic care setting, that you become so close to the patient and their relatives, and once you become so close with them, when they finally die, then you go so low. Okay, so we went further to find out the psychological impact of the work they do, and we realized that as large as 60% of these nurses indicated that they still had the impact of the work-related issues 24 hours after the event had occurred. So what it means is that they still carry these burnout issues with them to their home, and it follows them as far back as 24 hours, even after the event had occurred at the workplace. And even worse still, 73% of them felt that even after they had gone to the house, they still carried these emotional issues with them to the house. So by way of conclusion, the study showed a high level of burnout among pediatric oncology nurses. The unit need to draft a guidelines for supporting and training pediatric oncology nurses on self-care, where nurses themselves identify self-care strategies that build their resilience for long and successful nursing career. Thank you.
Good afternoon. Madam Chair, panel of judges, kindly allow me to stand on existing protocol to make my submission. So the title of my study is Quality of Life of Caregivers of Children with Sickle Cell, a qualitative study at Holy Family Hospital, Brekum. I'm Samuel Tebe Salamat. So we know that sickle cell is the most prevalent chronic illness seen among our clients, and caring for such children is quite burdensome, requiring a lot of human resource and financial investment. And it's known that that negatively affects the the quality of life of caregivers. And as our clients, as we know, our clients depend so much on their caregivers. And so the quality of life of caregivers of children with sickle cell directly influence the quality of care that these children get. And even though sickle cell is most prevalent in our environment, there's positive data regarding the quality of care of caregivers. That was the rationale for this study. So we sought to explore the caregiving burden of these caregivers and the influential factors that contribute to caregiving among primary caregivers that we saw in our facility. And the study was a phenomenological qualitative study that was conducted among primary caregivers of children with sickle cell who were seen at our sickle cell clinic in Holy Family, Brekum. And we used a convenience sampling method to obtain, to get 11 participants. That's when data saturation was reached. And the information was acquired through face-to-face in-depth interviews using a semi-structured questionnaire. And then the data that we obtained was analyzed using the computer software in vivo version 12. And after analysis, 3 main themes emerged. These were social demographic factors that influence caregiving, psychosocial factors that impacted on the care given to these patients, and then the various caregiving domains. With it, there were several sub-themes. Now, we found that with regards to social demographic factors, marital status, occupation, and religion play a significant role on the caregiver's experience. Also, social and family support were the main psychosocial factors that mitigated the caregiver's quality of life. With regards to the caregiving burden, financial and psychosocial factors were the major impact on the quality of life of these caregivers. Now, these findings were consistent with other studies in other parts of Africa and in the world. However, one significant thing that we found was that even though studies that were done outside, Africa, for instance, one by Madani et al., found that in Saudi Arabia and other places other than Africa, the social burden was more. But for us, we found that there was minimal social burden for our caregivers, which we are attributed to the close social support that is prevalent in our environment. With regards to the other findings, as I said, they were consistent with previous studies that were done. So to conclude, caring for children with sickle cell is not all about the financial support. We should go beyond and provide psychosocial support for these caregivers. And this study revealed the multiple challenges faced by caregivers. And so they need a holistic approach when it comes to caring for these children or these children in the family. Thank you very much.
Good afternoon, Madam Chair, panel of judges, ladies and gentlemen. This work was done by one of my house officers, Benjamin Sam. So if it goes well, it is my house officer. If it doesn't go well, it is the house officer's work. So we were looking at associated factors and outcome of babies with birth asphyxia in a district hospital in Kumasi. So what we did was that we know that birth asphyxia is a major problem within our country, and it's one of our top 3 causes of neonatal mortality in our country and in our region. And in our region, it probably is the number 1 cause of morbidity and mortality among the neonates. So what we wanted to do was to find out what were the reasons for the admissions of these asphyxiated babies, which facilities were referring them, and then to find out whether was there some trend that runs through that will inform us to be able to help these facilities better prepare for these births and then manage them. So we pulled data, we pulled folders, and then from the admissions and discharge book in the newborn unit from January 2021 to 2022. Our newborn unit started in December 2020. So he had a total of 56 asphyxiated babies, and that was what he looked at. So he found out that more babies were male, 66%, and then 34% were female. And what he found out was that those who came in less than a day, that's within the first 24 hours of life, were about 10. And then those who came in after the 24 hours were the majority. This was a bit on the sad note because you realize that more of the normal weight babies were asphyxiated. We would have expected that more of our larger babies should be asphyxiated, but it may have to do also with the proportions. So he found out that more of the normal birth weight babies were asphyxiated. And majority of the severe asphyxia cases came from other facilities. Those within our facility were on the lower side. And majority of the deaths also occurred within those who were referred in. When he looked at the causes, the factors that contributed to their asphyxia, we realized that it was things like the delayed second stage, fetal distress, malpositioning. Those were the things that were listed on the referral forms. And those were the things that the facilities also told us. And all of these things, majority of these things, we can do something about to be able to prevent birth asphyxia. One slide that I intentionally left out had to do with the facilities that referred the cases to us, because a number of the people from those facilities are here, and I don't have a police escort, so we left out that slide. But what it helped us to do was to help us know where the problems were coming from. And so we ended up going to some of the facilities to do training for them. And then we also ended up starting our perinatal conference once every quarter to be able to advise and encourage and educate the people about the conditions that they bring and the issues associated with them. One thing that I think I didn't show here was that most of the babies who died were those who came to us after the 24 hours. So this shows that those who came earlier within the first 24 hours had a better outcome. What does this talk to us about in terms of practice? This means that the initial management of the birth asphyxia within the facilities may also be a challenge. And therefore, we need to put in place interventions to improve the management of the labor itself, because realize that most of the problems had to do with the labor itself. So if you put in place interventions to manage the labor itself and the management of the asphyxiated baby, we will be able to reduce mortality from birth asphyxia. These are references, and would like to thank Prof. Dogbe, and then the rest of the team on the ground, and of course, Benjamin Sam. Thank you.
Right, I'll just let your chairperson say one or two words, and you can go and have your seat.
Thank you very much. Thank you, speakers, for sharing your findings and your knowledge with us this afternoon. I couldn't help but notice Barnabas' point. One of his points on the burnout was that the contributing factors was poor working environment. And I am hoping and praying that the Heal Confanoche project becomes successful so that in no time you can have an improved working environment. Thank you.
Thank you so much, Professor. Cake. Speakers, you can take your seats now. Thank you so much. We are on to the last session, and our chairperson has just walked in. For a few minutes, I had palpitation because we had changed his time and we moved it like an hour earlier. So, yeah. So I'm very happy that he has come. All right, the next section is going to be chaired by, there's a lot of funds given on that renal team. You give a lot of funds. They like giving funds. Haruna got funds, and Salamat, yes. We were looking for you. I think you were outside. Okay. All right. He even had a lot of questions and things. Okay, all right. Professor Emmanuel Adiobo is going to be the next chairperson. And Prof. Chairperson, please, can you take your seat at the judges' table, please? And this session is going to be a longer session. And I've told you the reason. The reason is because our judges need to have some very important meeting at 3 p.m. So they need to leave here. So we need to finish all the sections so that they can put their marks together. And then we will go for lunch. And then you come and hear who is winning what and who is winning what. Because they have to go to KNUST, back to KNUST. All right, so the next section is our specialized presentation. So from ENT, Dr. Mauto, please, are you here? Dr. Mauto, ENT. Okay, Dr. Dickens, I hear you standing for Dr. Mauto. All right. Palliative care, Dr. Barbara Oseye Setre. All right. And then we have another district presentation again. Dr. Jacqueline Esibe, she has driven all the way here. Thank you. All right. And then for hematology, we have Mr. Samuel Odum Frimpong. Hematology, right over here. And then respiratory, they have been ready from the first presentation. Dr. Stephen Chermatin Prempe. All right. I like the fans, but you reduce it a bit. Otherwise, there's too much pressure on him, you know. Too much pressure. I have seen that Sandra is coming to support him because it's not easy here. All right. Okay, let's start. Please start.
Good afternoon once again. So I stand on all previous protocols. and present for Dr. Mauto from ENT. So we are presenting an evaluation of hearing loss in children living with HIV at the Confanochi Teaching Hospital. So the incidence of hearing loss in children from developing countries is common. We know that a child's ability to speak and understand language may be hindered by difficulty hearing. Common causes of hearing loss in children include bacterial ear infections, trauma, cytomegalovirus, drugs, systemic infections such as HIV and TB. And HIV is known to increase the risk of developing hearing loss. So relatively little research has been conducted on hearing loss in HIV-positive children, despite the high incidence of HIV in the sub-Saharan region. There's a dearth of data in Ghana on the prevalence of hearing loss, as well as the specific risk factors that are to blame for the incidence of hearing loss seen in this population. So we conducted a 6-month prospective hospital-based cross-sectional study at the Confanochi Teaching Hospital Chest Clinic. And we recruited patients that underwent the following tests: biodata and detailed medical history taken. The ears were examined and an audiological assessment, which is the pure tone audiometry done. And then the data was analyzed using Status 17. Descriptive analysis was performed and presented in tables, graphs. Chi-square and Fisher's exact score were used to measure associations. And for all the statistically significant values obtained in the analysis carried out, it was compared to standard p-values of 0.05. So again, it looks like 308 is my number. 308 participants had hearing tested. The prevalence in HIV-positive group was 25.3. I think there's a slide missing. 154 were taken from the HIV clinic and 154 from pulmonology. So prevalence in HIV-positive group was 25.3, which is similar to other work done in sub-Saharan Africa. Prevalence in the HIV-negative group was 10.4, again, which is similar to prevalence in other studies as listed. So with the otoscopic findings, our most common finding was wax in the ear. That's the first. So the blue, those are HIV positive and HIV negative. So 46% had wax in the ears. And the least common finding was the ear polyps. Other findings included a perforated tympanic membrane, which was 9.1% in the HIV positive group, about twice the percentage of those HIV negative. A retracted tympanic membrane was 3 times as common in the HIV positive group compared to the HIV negative, which is suggestive of eustachian tube dysfunction. So with the type of hearing loss, again, the HIV positive is the blue one. 27% had conductive hearing loss compared to 11% in the HIV negative group. And there was a 3 times prevalence of sensorineural hearing loss in the HIV positive group. So across the board, having HIV puts you at an increased risk of hearing loss. So HIV status of the participants were found to be associated with hearing loss. A previous history of ear infection was also found to be associated with hearing loss. And a perforated tympanic membrane was also found to be associated. Demographic characteristics used in the inferential statistics were age, gender, educational status. However, there was no statistically significant association between demographic factors and hearing loss. So, in conclusion, prevalence of hearing loss is high in HIV-infected children, and this high prevalence emphasizes the need for periodic hearing assessment in the routine clinical care of HIV-infected children. Thank you.
Good afternoon. My name is Barbara Osei-Setre, a palliative care pediatrician at the Directorate of Child Health, Konfanochi Teaching Hospital. And I'm here to present on the accessibility of pediatric palliative care services in a tertiary hospital in a resource limited country. I would like to acknowledge the support of Dr. Vivian Paintel and Ms. Bernice Eklu. So pediatric palliative care is defined by the WHO as the active total care of a child's body, mind, and spirit, and involves the provision of support to the family. And it begins when diagnosis is made, and is supposed to continue throughout the disease trajectory, whether cure is intended or not. It is estimated that about 2.5 million children die each year with serious health-related suffering from life-limiting conditions and life-threatening conditions. And out of this, 98% of them are found in the low and middle-income countries. And sadly, this is where palliative care services are rare. And most countries do not have any pediatric palliative care services. And even those that have the service, there is poor integration into the healthcare system. So this study sought to evaluate the accessibility of children and their families to palliative care services and the factors associated with its non-utilization. And more so, it was a preliminary study to better understand the need for palliative care services as a new unit was being set up. So a quantitative study of data from the pediatric oncology units of the Konfanochi Teaching Hospital was done between January 2021 and December 2022. And a sample of 294 patients and 10 members of staff were used. And data was analyzed using Stata version 14. And this included the demographics, accessibility to palliative care service, the type of service that was provided, and the factors associated with the non-utilization. And with this one, interviews of some members of staff were done. So of this number, 169 of the patients required palliative care services. But that is 43%, that is 72 of the number were referred for palliative care services. And even with this, they did not receive the full and standard pediatric palliative care services. The patches of the service that was provided was mainly counseling and basic symptom management. And the factors that was noted to hinder the delivery of the service were lack of education and expertise on pediatric palliative care. Until recently, we didn't have anyone with the expertise in pediatric palliative care, and even the basic knowledge in palliative care was minimal in our health system. And also, there is no policy on palliative care generally in Ghana. It is now that stakeholder meetings are being held to have a policy on it, and specifically for pediatric palliative care. Another factor that came out was the fact that there was parental financial difficulties to access care when they needed the service. And also lack of access to some medications that are used in provision of palliative care, such as morphine, clonidine, gabapentin, and fentanyl. Morphine is readily available, but the oral preparation is not on health insurance and is very expensive, so it becomes very difficult to access it. Also, there is loss to follow up when cure is not feasible. We are still using the old method of care, that is, a diagnosis we intend to cure. At a point when we know that curative measures are not feasible, we tell the patients that there is nothing more we can do. So when they go, they do not come back again. and they are lost to follow up. So in conclusion, there is poor accessibility of palliative care services. And there is a huge gap in the number of children who need palliative care services and those who are referred. And even those who are referred do not get the standard service that are required. And also the needs of children and their families are not met due to resource inadequacy. The absence of policies and guidelines on pediatric palliative care also exists, and we hope that very soon guidelines will be put into motion for us to use it for palliative care service to be incorporated in all levels of care. Thank you.
Good afternoon. I'm Jacqueline Esibe. I'm grateful to the organizers of this program for this opportunity. So I'm presenting on strengthening sick newborn care at referring district hospitals to improve newborn outcomes in Techiman, Holy Family Hospital. This Holy Family is in Techiman. Good. God, there's Nkoko and there's Bekum. Good. Please, these are the authors of this abstract. This is my outline. Okay. So Holy Family Hospital is a secondary level facility in Bono East region. The top 7 referral facilities account for 11% of neonatal deaths at Holy Family Hospital. Analyzing perinatal audits show that poor referrals and inadequate capacity of referring district hospitals contributed to the high number of newborn deaths. With support from Medical Missions Institute, several interventions were instituted to improve the care of sick newborns at these facilities. So the main objectives was to improve neonatal outcomes at Holy Family Hospital. So the methods, stakeholder meetings were held between the Regional Health Directorate and the Holy Family Hospital to plan the structure of the project. The Medical Missions Institute provided both advanced and basic equipment for sick newborn care to support the top 7 referral hospitals. They also supported the long-term training of pediatric nurses, specialized nurses. So with this support, there was provision of both short-term training in both maternal and newborn care, and then supervision to these referral facilities, especially in the area of neonatal resuscitation, essential newborn care, intrapartum care, and then customer care. Specialized outreach services were also offered to these referral centers on monthly basis. Advocacy programs through the public health units of these hospitals was also sponsored. The results, so from October 2022 to March 2023, and that's the intervention period. So these results are actually the first phase of the project. We're in the second phase, there's also a third phase. 3 stakeholder meetings were held. 153 providers were trained in essential newborn care. And out of that, 28% were followed up on skills retention. 17 specialist visits were conducted to 4 referral hospitals. This is because some of them have pediatricians, so there was no need for us to go there again. Of which 60 NICU providers were mentored during these specialist visits on sick newborn care. 2 nurses were sponsored to be trained in pediatric nurses. I would want to say that the project wants to train 8 nurses, but there are some challenges with some facilities, specifically the Ghana Health Service facilities. They are unable to get candidates, and also challenges with steady leave, signing of steady leave. Each of the 7 referral facilities receive both basic and advanced newborn equipment. So some of the things, firefly phototherapy, incubators, monitors, and then the basic resuscitation bag and mask. So referral from the top 7 facilities marginally reduced from 37.5% to 36%. This is over a 6-month period. Neonatal mortality in Holy Family Hospital attributed to these 7 referral facilities reduced from 11% to 3% in 6 months. And the neonatal mortality rate, however, increased slightly from 35.5 per 1,000 live births to 36.6, but there is a reason why it increased. So this is a graphical representation of the referrals. So what we realized was that the referral, as we mentioned, reduced from these top seven facilities who are being mentored, and then, but referral from other facilities, specifically hospitals, private clinics, and other sub-district hospitals increased marginally. But more importantly, a death attributed to the 7 referral facilities, as I mentioned, reduced. But death from the other facilities who are not supported increased from 17% to 31%. And death from internal factors from the hospital itself reduced from 72 to 67%. So we realized that there was a marginal reduction. What is the aim of the project was achieved in terms of the supported facilities. But we realized that the other facilities not supported had increase in referrals, and especially even though the increase is marginal, contribution to mortality increase. So meaning they are bringing in more critically ill. And we also realize that there's also a decrease in the internal contribution, but the percentage is still significant. Okay. So recommendation that intervention should be extended to these other facilities. If not, we wouldn't achieve the main objective. And then definitely the interventions are Holy Family should be intensified, specifically in terms of training more specialized nurses and providing more advanced equipment. In conclusion, we realize that strengthening sick newborn care at referral hospitals improve the quality of care and referral from these hospitals to Holy Family. Thank you very much.
Good afternoon, everyone. Mr. Chair, all protocols observed. My name is Samuel Frimpong Odum. I'm here to present on a study we conducted at Komfanochi Teaching Hospital Outpatient Sickle Cell Clinic titled Predictors of Hospitalization of Children with Sickle Cell Disease in Komfanochi. The authors of this study declares no conflict of interest, and I'm going to talk through from the background of this study, the research objective, through to the limitation of the study. Globally, sickle cell disease is the most common inherited disorder among the hemoglobinopathies. SCD remains a significant issue in public health, particularly where in Africa, where over 300 newborns are affected yearly, and this number is expected to increase to 400,000 by 2050. Annually, approximately 2% of all live births in Ghana are diagnosed with XCD, with 6 in 10 having the homozygous form known as the sickle cell or SS. Due to multiple disease-related complications in SCD, children affected with SCD often require hospitalization. And as a matter of fact, in Ghana, there is, however, no consistent documentation on factors that contribute to SCD-related hospitalization. And based on that, the authors of this study sought to investigate the predictors of hospitalization among children with sickle cell in Komfanochi Teaching Hospital, specifically to determine the frequency of hospitalization, to identify the causes of hospitalization, and also to determine the factors that are associated with hospitalization among children with SCD. The study employed a cross-sectional study which involved a quantitative data approach from October 2021 to January 2022. As I said, the study was conducted at the outpatient clinic of Komfanochi Teaching Hospital, Sickle Cell. The study population for this study was all patients who were registered into the SPACO Ghana registry using simple random sampling. We sampled 421 participants for this study. Questionnaire was pilot tested at the KNUST Hospital which also has similar setting compared to the Confanoche sickle cell clinic. The questionnaire was answered by patient, SCD patient, and or caregivers. The questionnaire consisted of background characteristics of SCD, the clinical history of SCD, hospitalization history of the SCD patient. And in this study, we assessed hospitalization self-reportedly by the SCD patient. And for SCD patient who reported of being admitted or hospitalized at the clinic, we followed up in their health records to find the causes of hospitalization. The data was managed using research electronic data capture. We analyzed the data using STATA. Descriptive analysis was performed for all variables. Mean and median was calculated for all continuous variables, and multiple logistic regression analysis was used to determine factors associated with hospitalization among these SCD patients. Approval for the conduct of the study was sought from the CAT RIB. Assent was sought from SCD patients 7 years and above. Consent was also sought from caregivers as well. And based on the key findings, majority of the patients that we interviewed were males, and majority of them were between the ages of 5 to 14 years, with an average age of 9 years. Majority of them, that's more than 70%, were SS. And based on the clinical characteristics of this SCD patient, majority of them were diagnosed through the newborn screening. The average age at diagnosis for SCD patients who were diagnosed through the non-newborn screening was about 4 years. The duration of diagnosis was, the median duration of diagnosis was 5 years. Also, we also tried to find out whether this patient taking any homemade preparation in treatment of their SCD, and about 21% of them reported that they use homemade preparation in treatment of their SCD. Okay, we observed 38% of hospitalization among these patients, and about 36% reported that they have been admitted or hospitalized in the hospital for more than once, with a median length of stay of 4 days. The most common causes of hospitalization was VOPE, severe anemia, and acute chest syndrome. And for us to come out with the predictors of hospitalization, factors such as the SCD phenotype and also ever taking homemade preparation in treatment of XCD and duration of diagnosis were significant factors influencing hospitalization. The study reports relatively high prevalence of hospitalization among these children. The most common causes of hospitalization were VOPE, severe anemia, and acute chest syndrome. Duration of diagnosis of SCD and taking herbal preparation for treatment of SCD in the past 12 months were significant factors associated with hospitalization among this SCD patient. This study comes with some limitation based on the fact that hospitalization was assessed self-reportedly by the SCD patient, hence may introduce a recall bias and hence may not give a true picture of hospitalization among these patients. Aside all this limitation, the study still provides an empirical evidence on hospitalization among children with XCD. The findings of this study points to the urgent need that to address VOPE, anemia, acute chest syndrome among children with SCD, and also to intensify health education against the use of ineffective herbal preparation for the treatment of SCD. This study had funding from the Muhimbili University of Health and Allied Sciences under the National Heart, Lung, and Blood Institute, indicating this grant number. We also acknowledge the tremendous effort of the research assistants that helps in data collection, and also the nurses who were at the CAT outpatient clinic during data collection. The authors are also grateful to the study participants who voluntarily consent to take part in this study. We are also grateful for SPACO for making this work possible. Thank you.
Hello, good afternoon. So my name is Devin Prempe and I'm representing the respiratory team. So I'll be presenting on association between C-reactive protein and procalcitonin levels and outcomes in children, which were at CAT. So pneumonia, as we all know, is a primary contributor to mortality in children under 5. And there's an elevated incidence within young populations in Africa. So it's estimated that 4,700 children die with pneumonia under 5, and it's estimated that 4,700 children die with pneumonia under 5, underscoring the critical need for targeted interventions and public health measures to address this significant health challenge. So the reason why we did this study is that we've realized that C-reactive protein and procalcitonin are markers of inflammation, which has emerged recently in the assessments of severity of disease and onset and outcomes in children with pneumonia. However, no data exists on the use of these biomarkers to predict pneumonia severity and outcomes in Ghana. So our aims were basically to evaluate the levels of these biomarkers in children which were hospitalized at CAT. So we wanted to know whether when one presents with pneumonia, do these CRP and PCT levels go up or they remain the same? And also, secondly, to assess the relationship between the CRP and PCT levels and outcomes in children which were admitted at CAT with pneumonia. So we got ethical approval from CAT, and then a prospective cross-sectional study was conducted on children from age 2 to 59 months who were admitted with pneumonia within the months of April to August 2023. So we took consent from parents and legal guardians, and then data were collected on demographics, immunization status, clinical profile, and outcomes. About 5 mL of blood were obtained for the CRP and PCT testing using the Vitros 5609 diagnostic analyzer. And the data was cleaned and exported from REDCap to Stata SE version 16 for the analysis. So looking at the first table, so the first table shows the demographics. And from here we can see that, we recruited 109 patients, and then we had 15 mortalities. So majority of our patients were less than 12 months, and then 10 of them were male, so that was like 67%. So this table also shows the presenting vitals, and then we can see that majority of the patients who presented had a presenting temperature of less than 38.5. Also, majority of the patients who died had a presenting heart rate of more than 120 beats per minute. However, there were no significant association found between these initial presenting vitals and then mortality. So looking at other signs and presenting symptoms, the signs and symptoms which were predominantly present in our mortalities were cough. 93% of the patients who died presented with cough, 73% of the patients who died presented with cough, 87% of the patients who died presented with fast breathing. 93% of the patients who died presented with difficulty in breathing, 80% presented with weight loss, and 80% had crepitation in their lungs. However, looking at association between these signs and then mortality, we found out that the ones which had a great association between mortality was cough with a p-value of 0.020, seizures which had a p-value of 0.044, diarrhea which had a p-value of 0.013, and weight loss which had a p-value of 0.007, all being less than the standard 0.05. So this table was looking at the test of median difference. So to answer the first question, we wanted to know whether when one presents with pneumonia, do their biomarkers elevate or they remain the same? So looking at the median interquartile range of CRP, the average for those who died, or the median interquartile range for those who died, was 40.7, which was markedly elevated because the normal range for CRP is 0 to 10 milligram per liter. Also, for procalcitonin, the median interquartile range for the patients who died was 21.90, which again was markedly elevated because the normal range is less than 0.2 nanogram per milliliter. So in terms, when it comes to the association between this and mortality, the median interquartile range, as I said, for CRP was 40.70, and then for those who survived was 26.6, but there was no significant association between CRP and then mortality. But when we look at the procalcitonin, the median interquartile range was 21.90, which had a p-value of 0.019. So it meant that there was a significant clinical association between procalcitonin levels and then outcomes, which in this study was mortality. So for the discussion and conclusion, we found out that mortality from pneumonia in young children is still high at 14%. That is 1 in 7 patients will die. There were no association observed between the parameters for sepsis, which are temperature, respiratory rate, and heart rate, and mortality in this study. Cough, seizures, diarrhea, weight loss were all associated with mortality, and this was consistent with a study done by Bankole in 2013, which showed that severe wasting and seizures were associated with mortality from his study. We also found out that PCT levels predict death in pneumonia with children, and it was also consistent with a study done by Park in 2012, which his also had a positive association between PCT levels and then mortality. However, CRP levels did not predict death in this study. However, CRP levels did not predict death in this study, and it could have been. However, CRP levels did not predict death in this study, and it could have been to the small sample size. So these were my limitations. It was a one-center study, and it would not be generalizable to the general population. So the recommendation was that further multi-center studies are needed. Thank you, and these are my references.
So thank you, presenters. I'm making this announcement. There's going to be an infant nutrition and growth conference in Lisbon in Portugal on 11 to 17 February 2024. So get your passports ready, get your visa, and go and learn a bit more about nutrition to help your patients. Thank you. I'm going to give the microphone to our chairperson, Prof., and then when Prof. says a few words, then we open the questions, the floor for, there are 5 speakers for 5 questions because our judges are leaving in the next 10 minutes, so we have to finish up a little bit.
Thank you very much, and good afternoon, everyone. We've had very interesting presentations. It appears to me, I would wish we'd have had a longer time to look at it. And these are, the topics selected, I think it should be a source of encouragement to all those who are trying to write projects, choosing a topic. There is never an end to it. There are many things you can survey. Each of them is very interesting, and I'm sure you have a lot of wonderful questions. So let's take what you have to ask, and we'll see how together we can pick ideas from it, move forward, even support those who did those. I guess none of them has been published yet, is it? Good. And to support those who are working on those things. Very interesting, potentially. Questions, please. Trying to cut it short.
Dr. Hammond, I see your okay. Where is yes? It's 15th to the 17th in Lisbon, February 15th to the 17th. So that you have to apply for visa now. Okay. Ekuafo, I'm looking at you.
Okay, yeah. My question goes to Dr. Charles Martin Dickens. In the study that you presented, you said that hearing impairment was more prevalent in the HIV-infected group as opposed to the uninfected group. And you tried to explain that using infections or pathologies in the tympanic membrane as the reason for that. Now, I have two questions. First, were these infections opportunistic? In other words, were they caused by typical pathogens or atypical pathogens? And then the second one is that, based on the literature search, did you come across anything that suggests that HIV could directly affect the eighth nerve and lead to hearing impairment, considering that HIV is highly neurotropic? Thank you.
Thank you very much, Dr. Okay. Thank you very much, Dr. Hammond. It's times like this when I feel like I'm a poor substitute for Dr. Mauto. Anyway, so I'll try my best. So it was a cross-sectional study. It wasn't prospective, so we couldn't follow up events of infections of the middle ear, for example. But there was evidence of previous infections, such as the perforated tympanic membrane and history of ear discharges, etc. So that's to answer the first question. The second question had to do with whether in the literature search we had evidence of, yes. So, and I know why Dr. Hammond is asking this. So, he taught us HIV encephalopathy. So, yes, so there is evidence across literature showing that HIV itself has effects on your cranial nerves as well as the part of your brain that processes hearing. So simply, yes, there is literature for that. Thank you. Can I ask a question? I have the microphone. I wanted to ask Samuel a question that there's a push towards putting SS patients on hydroxyurea. I wondered why there was no association between hospitalization and hydroxyurea and why that wasn't analyzed. And then for Prempe, my question was, do symptoms precede the procalcitonin and CRP? I'm asking this because of utility. Should I be more attentive to checking respiratory rate, or I should invest my money in CRP and PCT? Thank you.
Thank you very much, Dr. Martin Dickens, for this question. Although clinically, hydroxyurea has been proven to reduce hospitalization among sickle cell patients, but due to our statistical analysis, it didn't show that way. That's why we ignored that in our presentation. Thank you.
So I would say no. Oh, no. So as you all know, the PCT is very, very expensive, and it's not even readily available in all facilities. So I would suggest that we take more attention to the clinical findings than the investigations. So that's what I would say.
Thank you very much. Good. Any more? But before that, can I also ask questions? So I look a lot at methodology to ask the questions. So the first question is, at what time did you take the sample for the procalcitonin and the CRP? When in admission? The reason behind is that people get pneumonia before coming home. Inflammatory process, some could be sepsis, otherwise. The longer they stay, theoretically, the higher these values are likely to be. The longer they stay in hospital, antibiotics they have are likely to be confounders in this.
Yes, Prof. Let me answer because I'm also an author. He can answer, but I'm adding on. So, no. So, Papa Diobo, actually, we couldn't provide all the information we used, but one of the criteria was that if a child had been on admission for more than 72 hours and had received any form of intervention from the referring facility, we didn't recruit. And then we took the samples for CRP and PCT within 24 hours on arrival to the ER department. Yes, so because remember we are a tertiary center and that will be a limitation. However, as we said, because we excluded those who had received interventions from other facilities, they've been admitted, antibiotics have been initiated and all that. We said we don't want that. So if they were coming in fresh within 72 hours of onset to us, then we take. But if there's been more, then we don't take them. Yeah.
Right. So my recommendations to those looking for topics is for those in the periphery to replicate this study looking at community-acquired pneumonia fresh. And just look at those within the first 3 days. You get very good. Let's 3 days, 1 week, let's say 3 or 4 days after the initiation. The rise of will you from when do you begin to get that the way these two things are going, I should act? Good. Any more questions? I have a lot to, but I don't want to ask all the questions. You have to go. Yeah, fine. So, when do we stop? No, I want other people to talk. Yes. Yes, I hear you are tired. You want to go for lunch, and that is important. But before HIV came, it was malnutrition, which was the main cause of secondary immune suppression. How do we know? And they had all the things that HIV patients are saying. How do we know that the hearing loss is purely attributable to HIV and not possibly confounded by a group of them that may have malnutrition? And maybe an answer to that is to check the nutritional status before doing these things. That would have been a good reflection in that. And there are many more, but because of time, stop. Thank you very much.
Thank you very much, Prof. Chairperson. All right. So, you know that this conference is being done together with PSG, Pediatric Society of Ghana. Actually, we are all part of Pediatric Society of Ghana. You understand? Our chairperson is in. I'm so excited. For a moment, I just had a bit of palpitation looking for you, Prof. All right. Okay. So, without wasting much time, I'll say that please let's pay our PSG dues. Esther, our beautiful Esther, sitting right out there at the LOC table. You'll find her there. She's actually waving at us. You can see her, a beautiful Esther. And for pediatricians, it's 240 Ghana cedi per annum. And then other professionals, nurses, pharmacists, allied health professionals, is 120 per annum. So please, we are all PSG members. Please pay your dues as it's getting to the end of the year. Thank you very much. So now, just go for lunch. By the time you come back, our judges would have put the results together, and then we would know, we would just, our chairperson will give his response. We will hand over the awards, and then we'll call it a day. Thank you very much. Please go for lunch. Thank you.
Hello.
Hello, hello.
Can we all come in? Can we all come in for the closing ceremony? Yeah. All right. Can we all come in? Salamat and Dr. Okran, I see you. All right. Akwete, can you come inside? Yes.
I don't know the person who did this.
I will tell you. Wait there, my auntie. Please, you have QR codes on your table. Here for some time, and he will give his closing remarks. HOD will give his closing remarks first, and then the chairperson will give his closing remarks, and then I will give the closing prayer. If you don't sit down, I will pray for 30 minutes. You understand? I'm threatening you. All my problems, I'm going to pray it today. Aha. I know them. Yeah, that's it. MBU4. MBU4. Yes, that's the first session, the one you were here. Yeah, that's the one you were talking about. I just get. Yes, please. Hey, Adoma, Jomo. This one is a dummy, so it doesn't matter. Or we need me. Or we need me. Ebi mo we need me. Because it's not only you, it's also the so okay. It's metro. What do you say? So communication. The communication. Next time, okay. To the last. Yes, please. Stephen got it in Chairman Team. Pardon? All right. Okay. So I would like to call upon Professor Linda Fonjo to come and give The first, for the best oral presentation, please, is going to Hope Exchange, Adoma Jumofoko, and her house officer. Where is she? Is she around? And please allow her to come. Let's keep clapping. Should I give it? The title is Associated Factors and Outcomes of Babies with Birth Asphyxia in a District Hospital. All right. Congratulations to the house officer and for you for supervising it. All right. Okay. I think even the house officer has finished and has left. The house officer is now in Volta region. Yes. Doing senior house job. Okay. The second best oral presentation goes to Vivian Painsel. Spatial coherency of artisanal mining and pediatric cancer in Ghana. We would like to call Prof. Adiobo to do the presentation for us. To Vivian Painsel, please. Yes. Okay, sorry. Please clap. Keep clapping. Thank you very much. Congratulations, Vivian, and your team. All right. And then the third best oral presentation goes to Stephen Chermatin Prempe. The topic is association between C-reactive protein and procalcitonin levels and outcome. Stephen Chermatin Prempe. I would like to call Dr. Mrs. Planjou to give this presentation to Stephen Chermatin Prempe. Yes. Okay. Well done, Stephen. So now we are going to go to the... You're going to take a picture. Okay, sorry. All right. So now we are going to go to the best poster presentation. The best poster presentation goes to Jumo Foko Odame of Hope Exchange. Best poster presentation is going to Jumo Foko of Hope Exchange. And I would like to call on Dr. Pupulampo to come and do this presentation. Sorry. Well done, Hope Exchange, Dr. Jumo Foko. Well done. All right. Okay. The second best poster presentation goes to Dr. Vivian Painsel and her team. Research. All right. And it's being given by yours truly, myself, Mima Award. Miss Mima Award. Chiamia. Well done, Vivian. All right. Okay. And the last one, the third best presentation is going to be done by Dr. Mrs. Planjou again. And it's coming to my ward. Oh, Ekia Okran. My ward has won an award. Oh, my ward. Hey. MBU. MBU. Please give us fans. MBU. Give us fans. That's right. That's right. Please continue the fans. That's right. Aha. Well done, Ikea. Well done, Ikea. Well done. Well done. Well done. Very proud head of unit. You understand? Manya who but major fans. You understand? Aha. Okay. All right. So on that note, we are going to let the HOD give his final remarks, and then the chairperson will give his final remarks. We'll give vote of thanks, and then we are out of here. Thank you very much.
So, thank you very much. Thank you very much, and congratulations to all the award winners. You deserve it. You've done a very good job. And everybody else who presented has also done very well. If you have data sitting out there, don't churn out into a research presentation. It is of no use. And so you've all done very well for presenting. I think the number of abstracts we receive is quite a lot, and you've done very well. We all deserve applause. Can we clap for ourselves? There's one demand. I said it earlier in the morning. Once you're able to put together your data to even submit as abstracts, but once you do that, you definitely stagger it along how we write scientific report. And so I'll beg all of you who have submitted abstract, when you go as a team, sit together, look at it, and see how you can develop it into manuscript. It is good that have been disseminated here. We are here, maybe also posted in another website, KNUSC, our own child health website will be there, things like that. People will get abstracts, the whole abstract book will know. But if it also gets into scientific journal, the audience is larger. So I'll beg you, don't let it end here. Just think about how we can translate your abstract into a manuscript. Let's work on that. Like I said that, I'm considering seriously to get a research coordinator for the department who will be looking at all these things, together with many other things. You've all done very well. There was one particular research work that sat with me so well. Remember, I've said that everybody has done very well. We care for ourselves. But that one, it sits with me well because I see in our practice one thing that is lacking. It is our communication with caregivers. It is lacking in our practice. And because of that, we have gone to the extent as a department through a series of retreats and workshops, spent a lot of money. We have developed an SOP. It is finished. It is at the printing stage. Early next year, we're going to launch it. Everybody who works in child health will have to abide by that. It cut across every aspect of our practice, from nurses, doctors, pharmacists, the things we are supposed to do, and it includes communication with patients, because it's lacking. And so that presentation really sit with me, and I've done very well. I hope that you can also develop it like I've recommended for all the others. Assessing communication between healthcare workers and primary caregivers in the mother and baby unit. And you see that even though 73.3% of mothers have been told about what their babies had, but in reality, the diagnosis that match with what is in there, for us were 66. So sometimes the way we communicate, don't communicate very well. That is lacking. Let's go to hospital. Anybody is admitted or is discharged from the hospital, meet the person. Ask him, what were you told as a diagnosis? What is wrong with your child? How can we be practicing like that? The person doesn't know what was wrong with the person. And so it is something, and definitely for us, the SOP that we have developed, that we're definitely going to launch and implement in our departments is going to address some of these things. We've done very well. I cannot thank the LOC anymore. I have said it earlier in the morning. We have done a yeoman's job. Let us keep the spirit up. And my special appreciation goes for those who came from the district. Almost all the regions in Ghana are here, and that is very good. I'm sure yesterday in my speech I said it. I said, Directorate, we are very open to extend hands to wherever you are in your practice. Feel free to consult us. We have got about 13 or so subspecialty units. If you have any case in this unit, just reach out to us. We'll be happy to guide you and to help you so that together, wherever a child is found in Ghana, we can all help with the outcome of that particular child. So with that, I say equal to everybody for participation. Let this knowledge and the skills we have acquired here translate into improvement in the service that we give to patients going forward. But remember, will happen again next year, because that, once we have resumed, going to be an annual event, because the research will be a biennial, so it means every 2 years we combine it. Thank you all, and I wish you safe journeys when you are going back home. God bless us all.
So I would like to make this small notice to every one of you. The souvenirs that we gave to the awardees is coming from the Office of the Grant and Research, and it's by the kind courtesy of our chairperson, Professor Philip AJ, who is coming to give his closing remarks, and then we are out of here, please.
Shall we applaud for Eno? Yours what? Yours truly. Okay, so let me stand on the existing protocol that we established in the morning. You all agree with me that it's been a very wonderful, educative and informative research day. Let's applaud for ourselves for that. In the morning, our Pro-Vice Chancellor, Professor Ellis Owusu Debo, took us through, who was the main speaker, took us through ensuring excellence in emergency pediatric care 20 years on. He started by saying that out of every 1,000 live births in Ghana, 48 children died or had the probability of dying before reaching the age of 5, according to WHO 2020. He took us through the current situation and then what could be done to improve emergency pediatric care. He mentioned a number of things, including an integrated service, child and family-centered service, quick initial assessment of an ill or injured child, and standardization. He went on and on to highlight what could be done. Following on from that, Professor Entry Kusi recounted a number of things and the need to demonstrate compassion and other such attributes for pediatric emergency care. We are also welcomed by our head of department. Shall we do it better for our head of department? Who welcomed us and then made us to settle. Following on from that, we also heard from the UNICEF representative, Dr. Tremartin Amoa. What struck me with his presentation was the need to safeguard our children against mercury poisoning. Professor Daniel Anson, the immediate past dean, walked us through the need to use data to improve emergency care. He noted the sources of data could be historical, from the laboratory, radiology department, and then clinical information. He highlighted the attributes of data that are relevant for emergency care, including those that have been systematically collected using standardized protocol with appropriate ethical considerations. Professor Anson also provided a SWOT analysis of the PEU for data generation for clinical care. Importantly, he walked us through the many peer-reviewed publications using data available at the unit. You all agree, therefore, with me that we've been treated to a cocktail of various presentations. We had 6 sessions of presentations on various relevant and contemporary topics and issues and in pediatric emergency care. We also had 15 posters from various units, including the pediatric critical care, respiratory, infectious disease, to mention but a few. I hope I've mentioned your unit. Importantly, we also had presentation from the district hospitals, and that is quite impressive, and we should applaud for all those who came from the various districts hospitals to join us this morning. As I indicated in my opening remarks in the morning, these presentations provide unique opportunities for learning and future research ideas. It also provides networking opportunities for future collaborative research endeavors. We've all done so well, but let me add to what our Professor HOD, Professor Sampson, told us. And for me, one of the presentations that struck me most was his presentation. I grew up partly in a village where we used to swim. One of the things I have decided I know I will never be able to do before I leave this earth is swimming. Even though I grew up where there was a river, yet I'm still unable to what? To swim. So I've closed that chapter in my life. But I mean, a lot of my friends and a lot of people that I know had, and sometimes we think it's normal. So thank you very much, Professor, for highlighting this. Shall we do it better? Shall we do it better for her? I mean, all of us have done well, but let us turn this into manuscripts. Let us turn this into what? Into manuscripts. What will interest me as a director and what will interest the university is the publications arising out of this what? Conference. Funders will not count how many abstracts were what? Submitted. What counts for the university is how many manuscripts are developed from these what? Abstracts. So as you go home, 21 presentations, oral presentations, and 15 posters, that is about 36, isn't it? 37. Okay, I'm told it's 37. So if you have 37, even if we get half of this being turned into what? Manuscripts. I mean, that would be quite impressive. Let us work on that to get manuscripts for the university. I've enjoyed myself this afternoon. I've made some new friends, and I'm hoping even before I leave here, I'll make some more friends. Once again, I congratulate the Department of Child Health, KNUST, and Komfanochi Teaching Hospital. And as I said in the morning, I believe that this is just the beginning of greater and better things to come. On that note, I say thank you, and God richly bless us all. Thank you.
Thank you, our chairperson, Prof. Nchieje. Please, on your tables, we have the QR evaluation form, but you have to use your QR scanner on your phone, okay? It's on your phone. Charles Hammond is on your phone. Just scan it and then fill the evaluation for us. Please, I beg you, okay, so that we can make it better. We know we are coming back for the conference again somewhere in May, God willing. We have not thought about it, but it's not going to be beyond very long from now. We just want to come back much more improved and give you a better conference. Okay, so please scan it and then fill the forms for us on your phone. All right. And then, the drinks are going around. Please make sure, because we are leaving a lot of drinks behind, okay? If you are not diabetic, please make sure you have something to drink, okay? Don't you have something to drink? Okay, on that note, I would like to thank our chairperson, Professor Nchieje. Can we give it up for him? Coming all the way from the morning, and then all protocols are observed from the Vice Chancellor, the Pro-Vice Chancellor, and the Dean, the immediate past Dean, and all the professors in DCH, Dr. Planjou. I'm not supposed to say Professor Planjou, but I've said it anyway. She's looking at me like, hey, no, be careful. I know, HOD. Okay, and then all of you coming from various places, God richly bless you, every one of you. Those, I just pray that the Lord will take you there. We thank the Lord for a successful conference. And we all know that, those of us in LOC, it's not been easy, isn't it? It's been statement upon instructions upon counter instructions are done and all the time trying to, and then my team, I want to say special thank you to my team for our financial engineering. We know we learned from Wyoming. That's why you're all sitting here. We've done a bit of financial engineering. You understand? So thank you, my team. I know they are still there trying to sort and finance out. Dr. Reku Brobe, thank you, you and your team, for doing a very wonderful job. And thank you for coming, because if you had not come, it would not be wonderful. Thank you, all of you. And of course, as I said, our major thanks go to God for making it possible. There's been no rain. We had a wonderful climate, and we are here, and everybody has gone and come back. I'm praying that we'll hear that you have all gone to your facilities, and whatever you have learned there, you have taken it there. And we have built relationships, okay? Yes, we are here. Call us. Anything that is bothering you at your place, okay? Just call us, and then whatever help we can give, as Prof said, we will give that help. God bless all of you. Shall we stand on our feet and take the closing prayer? And after that, we can all go back home. Thank you very much for coming. Father, we thank you. We started with you. It's been a wonderful 2 days. We've been envisaging that today we are going to close at 7 p.m., but that has not been. And this is all because you gave us wisdom on how to cut down time, but still achieve our aim, which we were able to do. We thank you for all those who came, our judges who had to go for meetings, but they still made it. All the people, invited dignitaries who came, we are praying that bless them. Remember the Vice Chancellor, more wisdom for her and her team with the Pro-Vice. Remember our chairperson who has been here with us from morning till evening. All the people who are here, the people are coming from various places, may you take them safely. We plead the blood on every single soul here. That, Lord, we will not hear any negative news. Everybody will reach to their destination in safety, so that at the end of the day, whatever we have learned here, we will go and give it right back to the children that we are privileged to look after. And then we will come back again next year by your grace again to come and learn more new things so that we can impact the children of Ghana. In Jesus' name have we prayed. Amen. Yes. So we have finished the meeting. Please socialize and everything. The conference will be in May or April, okay? Last week of April or first or second week in May, okay? So plan. Elder, let your facility plan, okay? So that you be coming, okay? Not GMA meetings alone. I'm looking at you. All right then. Have fun. All right.